I'm the chair of medicine at SUNY Downstate and also director of this, co-director of this symposium. I'm joined by Dr. David Tuvison, who is director of the Cancer Center at Cold Spring Harbor Labs. Together, we bring greetings to all of you. I will make some few remarks, and then Dr. Tuvison will make additional remarks. Following that, I would introduce Dr. Marlene Camacho, who would preside over the session one. And then I would come back at the beginning of each session to introduce the moderator for each of the sessions. Just a few housekeeping stuff. One is that please keep on time. This is a Zoom meeting, so we want everyone to be on time so that we can move to the next sessions without delay. Each speaker has 20 minutes. Try to be around the 20 minutes. And then at the end of each session, we have 15 minutes for questions and answers. We will try to keep those two as pristine as possible. Then we would have a break. The first session ends at 10:20. There will be a break from 10:20 to 10:30, 10 minutes. We'll take a Zoom break, and then we'll resume again at 10:30 to introduce the second session, which is going to be focused on pancreatic cancer. That session has 3 speakers. Then there will be a lunch break from 11:30 to 12:30. And then we come back for our keynote speaker, Dr. Edith Mitchell from the Thomas Jefferson University. And then there will be questions and answers following her keynote speech. And then we move on to session 3, which is the cancer and comorbidities and modifiable risk factors. That would start at 1:20 and then end at 1:40. And end at 2:35. And then there will be closing remarks, and then the symposium will be adjourned at 2:45. So that is the plan of the day. So again, welcome. I'd like to thank our, long-standing supporters. They were the program advisory committee or the external advisory committee for the NIH-funded project that we had with Cold Spring Harbor Labs, SUNY Downstate Cold Spring Harbor Labs, and then SUNY Stony Brook in 2015. The project lasted for 5 years, and that was the genesis of this conference. Since then, we've been able to continue the conference with institutional support between SUNY Downstate and Cold Spring Harbor Labs. I would like to thank Dr. John Carruthers. He is the chair of medicine at the Michigan, University of Michigan at Ann Arbor. He's the John G. Seal Professor of Medicine over there, and he's just an amazing supporter of our program. And also I'd like to thank Dr. Anthony Baines. He is at North Carolina Central University. He's also been part of the external advisory committee, and though the NIH funding has ended, they continue to participate in the activities every year. And so we are so thankful to them. All right, so in the United States, African Americans, people of African American descent have high incidence of GI cancers and a lot of other cancers as well. And the mortality appears to be high in African Americans compared to other ethnic groups. That is the foundation of this symposium, to begin to understand what is responsible for these differences. The symposium aims to inform investigators and clinicians, trainees, students, and other members of the public in understanding biological differences contributing towards racial and ethnic differences in colorectal and pancreatic cancer, and on comorbidities, some of them modifiable, some non-modifiable, and how we can approach those issues to address this huge disparity in cancer incidence and prevalence between African Americans and other ethnic groups. The symposium also seeks to establish new collaborations. We're always in NIH mode, trying to establish links and new faces. I can see Dr. Roper nodded his head. That is one of the reasons for this symposium, to establish collaboration so that when we come up with new projects, we have enough manpower or woman power to be able to put very interesting projects together to address these cancer health disparities issues. Our keynote speaker today, as I mentioned before, is Dr. Edith Mitchell from the Thomas Jefferson University in Philadelphia. She's an amazing person. She also runs the Center for the Elimination of Cancer Health Disparities at Thomas Jefferson University. We are so pleased that she accepted to give this keynote speech, and we're looking forward to her talk. So on behalf of SUNY Downstate, the Brooklyn Health Disparities Center, and also Cold Spring Harbor Labs, I would like to welcome all of you to this 7th Annual Cancer Health Disparities Symposium. And I'm looking forward to all the talks and the take-home points that we can use to improve the care to our patients. So I would like to invite now my colleague, Dr. Tuvesen, to also give some opening remarks.
Yeah, thank you so much, Dr. Salufo. And I also want to welcome everybody to our 7th annual symposium today, and thank my colleague, Dr. Laura Martello-Rooney, for doing the lion's share of the work of organizing us and putting together another virtual meeting, which in many ways are more complicated than the live meetings, as we've all gotten accustomed to. I predict that next year's meeting will be in person. And we, of course, will look forward to seeing all of you then. So as Dr. Salufo said, approximately 7 years ago or 8 years ago, there was conversations that started between Cold Spring Harbor Lab, SUNY Downstate Medical Center, as well as SUNY Stony Brook. And the topic was exactly the one he enunciated. Why is it that certain populations have more cancer and worse cancer than others? And the focus, of course, were on the 2 GI cancers that he mentioned, colon and pancreas. Well, 8 years ago, we didn't know why. And I would say if we come forward in time to where we are today, we're getting closer to starting to understand the topic. So the two, likely scenarios are there something about the access to healthcare or something about the health of the individual when they start. So something intrinsically biologically different, or something, about folks who don't have as much access to care. The cancer rates amongst individuals who live in difficult situations, who have a lower socioeconomic status, is higher than those who aren't. And that goes across ancestries, across races in our own country. For example, the Ohio River Valley, which is predominantly a Caucasian population, have the shortest lifespan of people in our country. And so access is a big deal. And other attributes to folks who live in disadvantaged situations are, contribute to that risk. But we also know that by studying the genetics and the biology of different populations, we're learning what can be distinctly identifiers between different races. So for example, esophageal cancer, lower esophageal cancer in the United States and Western Europe is very common and in growing in incidence. It is very uncommon in individuals of African ancestry. And we now think we have a molecular understanding of why that is. Barrett's esophagus is very rare. There's a gene that has been identified by David Beer from Michigan, where Dr. Carruthers is the head of GI. GSTT2, which is a glutathione transferase gene, works great in African individuals, works terribly in European ancestry individuals due to a polymorphism, an internal duplication in the promoter of the gene. So it's a hypomorph. So that was interesting. So that's a protection allele. We're looking for susceptibility alleles, though, in the situation that Dr. Morrow is talking about. And together with Laura, our laboratory, and other scientists at Downstate and Stony Brook, we have put together collections of patients that we're now studying their tissue and even growing samples of tissue in something called an organoid. And what we've done is developed a group of people working together long enough that we have applied for other funding sources, both federal and non, and have acquired and secured support from the New York Genome Center in 2 projects called Polyethnic 1000, where we continue to study this concept, where samples are being collected and sequenced, et cetera. And that's with another partner of ours, Northwell Health, which is a very large healthcare provider on Long Island and New York. So we're pretty excited that we're on the right path. I think that Dr. Salufo will be pleased to hear that there will be additional applications for federal funding based upon the findings that we're going to have from our studies. But we'll only get there by teaching each other what we learn and bringing in experts from the outside, such as those that Laura have been able to attract today to give these lectures. And so again, I welcome all of you to our seminar today, our symposium today. I look forward to seeing you in person next year. And this is a topic which we started on 8 years ago when it was not topical. And now when you open the newspaper or you read whatever cancer letter, et cetera, it's the top line on it. And so we were kind of a pioneer in understanding this back then. And again, I'm so grateful for the collaboration that we have with our colleagues at Downstate and Stony Brook and now Northwell to study this topic. So thanks for all your support. Bring your ideas to the table and ask questions of our speakers. And we hope you learn a lot today so that you want to enter this field and work on it with us. Thank you. Oh, and I didn't say this, but I'm the Cancer Center Director at Cold Spring Harbor, if that wasn't apparent.
Very nice. Thank you very much, Dr. Tuvison. All right, so we are on time. It's 8:45. I now have the pleasure of introducing Dr. Marlene Camacho Rivera. She'll be taking over for session 1, which is going to be focused on colorectal cancer. The theme here is mechanisms of obesity-associated colorectal cancer. Dr. Camacho Rivera is Assistant Professor of Public Health in the Department of Community Health Sciences. She's actually a trained chronic disease epidemiologist, which means everything around chronic disease. She's just the person to talk to. I know her very well, and she has outstanding understanding of epidemiology and how chronic disease intersects with cancer. More recently, we had a very important NIH application, which is actually centered around the same subject. So I'm very pleased to welcome her to chair this session on colorectal cancer. So Marlene.
Thank you, Dr. Salafu. It's my pleasure to introduce our first speaker for today, Dr. Jatin Roper. Dr. Roper, just to provide a brief introduction to his many accomplishments. Dr. Roper received his BA and MD degrees from the Boston University 7-year medical program. He completed his internal medicine residency at NYU Langone Medical Center and his gastroenterology fellowship at Tufts Medical Center. He has completed additional research training programs at NYU, Tufts, and MIT. And in 2019, he joined the faculty of Duke University School of Medicine as an assistant professor of medicine and assistant professor in pharmacology and cancer biology, and as a member of the Duke Cancer Institute. And Dr. Roper will be presenting his talk today on mechanisms of obesity-associated colorectal cancer.
Right. Good morning, everybody. Thank you so much for the introduction. And thank you to the organizers of this meeting for inviting me to speak. I really do appreciate it. As a former resident of New York, I was hoping for the opportunity to go back and meet you all in person. And as Dr. Tuvison mentioned, I hope we have the opportunity to meet in person at future meetings. The title of my talk is Mechanisms of Obesity-Associated Colorectal Cancer. I want to echo Dr. Tuvison's point that cancer disparities can be driven by both socioeconomic, access to care issues, and potentially also biological differences that may be driven by those factors. And so the focus of my talk for the first half, I'll describe a little bit about the clinical data behind how colorectal cancers form and the data behind obesity being a risk factor for colorectal cancer. Then the second half of my talk, I want to describe just a few, I think, seminal papers in this field, in the basic sciences, that touch on different possible mechanisms by which the obese state and a high-fat diet-induced obesity in particular can promote colorectal pathogenesis. So just a quick overview of colorectal cancer statistics. Other speakers will, of course, touch on this in a bit more detail, but it is a major cause of cancer as well as cancer mortality. In the United States, there's 150,000 cases per year, 53,000 deaths per year. It accounts for 9% of all cancer deaths, and it's the second leading cause of cancer mortality in the United States. So clearly, despite our efforts in screening, as I'll talk about, still a very major cause of cancer death. A lot more work to be done in this area. I'd like to give a historical perspective on how we got to where we are today. If you look back to the 1970s, it was not known at all where colon cancers come from. Observational data from pathologists suggested that in colon cancers, you could find residual benign adenomatous tissue, adenoma being potentially a precancerous lesion. By the time it was not well understood. Conversely, larger polyps in the colon were sometimes found to have malignant foci on the right I'm showing you an example of a polyp in the colon that has an area of carcinoma adjacent to adenoma and normal colon. And rarely clinicians would observe a benign appearing polyp developing into an invasive cancer. And so additional data, this landmark paper from 1987 followed patients who at the time declined to remove a large polyp. It would have been a surgical resection. There's a bit of uncertainty about whether it was necessary, but following these patients for 20 years really showed that having a polyp in the colon substantially increases your risk of developing cancer over a 20-year polyp, both at the site of the index polyp as well as elsewhere in the colon. Additional data from the SEER program and from others has shown that the risk of both polyps as well as colorectal cancer increases with age. And so all these data together, I think, have led to an understanding of how normal colon can progress through the adenoma precursor into cancer. This together with landmark research from the vocal screen group and others has identified genetic drivers of this transition from normal colon to adenoma to carcinoma. And just to summarize our understanding of this genetic progression, we believe that normal colon tissue is transformed by activating mutations in the Wnt signaling pathway. And so that's usually driven by loss of the APC tumor suppressor gene or activating mutations in beta-catenin. That then gives you a polyp. Early polyps for adenomas can acquire mutations in oncogenic KRAS in about 30 to 40% of cases. These can progress into late adenomas, and then more additional mutations can be acquired later in the progression, such as loss of TP53, activation of PIK3CA, loss of SMAD4, and other mutations. These then lead to invasive cancer. This understanding is critical because the survival from removal of an adenoma is close to 100%. The survival for removal of a late adenoma or a stage 1 cancer is extremely high before invasion. But once the cancer has invaded into the muscularis, the serosa, and spread lymph nodes, then you have stage 3 cancer and survival dramatically decreases. Therefore, it's imperative that we understand mechanisms of this process as well as increase access to screening, colonoscopy, and other modalities to detect precancerous lesions. On average, this process takes 10 years, which provides us with a window for intervention. So all this data I've just really briefly summarized so far led to the hypothesis that detection and removal of these advanced adenomas, meaning larger, 1 centimeter larger adenomas, and early carcinomas will reduce mortality for colorectal cancer. And so I just want to summarize our guidelines that just were updated last year by the American College of Gastroenterology. They recommend colorectal cancer screening in average risk individuals starting at the age of 45. This is a change from prior recommendations that started at 50. And I'll get into why. It's between 45 and 49. It's a conditional recommendation based on the lack of direct randomized control data. And we recommend screening up until the age of 75, after which is individualized. Our primary modalities of screening, colonoscopy and fecal immunochemical testing. And just briefly mention that beyond these two preferred modalities, there are a number of other alternative programs for colorectal cancer screening that patients and their clinicians can choose from. Okay, so what has the impact of screening been? So the good news is that screening uptake has increased over the last 20 or so years, 37 to 67%. We have not reached the goals that we as doctors proposed, but we've made progress. Coincident with the increase in colorectal cancer screening uptake has been a decrease in the rate of colorectal cancer, both new cases as well as death rates. So that's the good news. However, I think the biggest story in this field in the last few years has been the as yet unexplained rising incidence of early onset colorectal cancer, which other speakers in the session will discuss. What I'm showing on the graph on the right is from the top to bottom is starting from different birth cohorts, what is the rate of colon cancer? And in older age groups from 50 up to 85, there's been a decrease in colorectal cancer incidence, depending on the birth cohort. As you go down to younger groups, however, you see that the rate is increasing. And among the group from 25 to 29, you see that the incidence has gone up both for colon and for rectal cancer. And so in summary, among adults younger than 55, there's a 51% increase in the incidence from 1994 to 2014, an 11% increase in mortality. This is a big deal, such that a 45-year-old today has roughly the same risk of developing colon or rectal cancer as a 50-year-old did 20 years ago. It's presumed, based on my understanding from the epidemiologist's field, that this is likely driven by environmental factors. And I'll propose today, and consistent with the epidemiologic data, that obesity, the rising incidence of obesity, can be potentially one driver of this rising incidence of early onset colorectal cancer. In addition, although I'm not showing the data today, the rising incidence of obesity can potentially explain part of the disparities in colorectal cancer risk in different minority populations in the United States and internationally. So therefore, I believe that the question of how obesity drives colon cancer is an important one from a public health standpoint. So this paper summarized modifiable risk factors for cancer. Smoking is by far the largest modifiable risk factor for cancer in general. Thankfully, smoking rates are going down in the United States. However, overweight or obesity status continues to rise, and that is the second highest modifiable risk factor for cancer. Overall, it seems that obesity increases the risk of colon and rectal cancer by about 2-fold to 2.5-fold. And given the numbers we're talking about, that can translate into a substantially large increase in cancer risk and mortality. Many papers have studied this. I just want to mention one paper that I just saw published a week ago, so hot off the press, from a group from Germany. And what we're showing you here in blue are the risks of a diagnosis of cancer. These are GI cancers: colon, rectum, pancreas, and liver. Women on the left, men on the right. Blue is normal weight, orange is overweight, and gray is obese. And what you can see is that there's a dramatic increase in colon cancer diagnosis in both men and women as you go from normal to overweight to obese. Body BMI ranges are shown on the right. However, interestingly, I think the rectal cancer risk was increased in men, but not in women. And you can also see that overweight status increased the risk of liver cancer as well. So there may be a tissue-specific role that obesity plays that's not exactly well understood. But I think this adds to the growing body of epidemiologic data showing that obesity promotes colon cancer risk. All right, so now I just want to spend the last 5 or 7 minutes or so that I have remaining to discuss a few recent studies that have predominantly been based in animal models, mouse models, to study mechanisms of obesity-associated colon cancer. Why study mice? They're small, they're easy to study, they're responsive to obesity, so we have nice models. And so we can study the obese mouse, compare them to the lean mouse, and try to draw conclusions that may be applicable to our patients. So just to summarize what I'll show you, one theme of how obesity can promote cancer is metabolic reprogramming in intestinal stem cells or epithelial cells, which can increase stem cell numbers and tumor initiation. Another theme is a growing recognition of how the immune system plays in in colon cancer function. That reprogramming of cancer cells can lead to impaired T cell function and anti-tumor immunity. Also, the gut microbiome is believed to play a role in this process. And so gut microbial dysbiosis can result in metabolic alterations and promotion of cancer. And finally, the last thing I'm going to mention is there can be signaling from fat cells themselves, adipocytes, to the cancers that may promote cancer growth. This is work I did in my postdoc at MIT, together with Samir Bayaz at Cold Spring Harbor and Miyako Mana, who's in Arizona now. I'm showing you a cross-section of an intestinal crypt. So P is Paneth cells, S is stem cells. Stem cells are the cell of origin of cancer. And what we showed is that in the setting of diet-induced obesity, there's metabolic reprogramming of stem cells, activation of this pathway called PPAR delta. PPAR delta promotes activation of the Wnt signaling pathway, which drives expansion of stem cell numbers and also allows differentiated cells, transit amplifying cells, to expand in numbers and act like stem cells, both in vitro organoid culture as well as in mouse transplantation models. And so what you have is really more stem cells, and then you have non-stem cells functioning as stem cells, and you have activation of this Wnt signaling pathway. All those factors together increase the propensity of cells to initiate cancers of the colon. And so this gives an example and highlights how metabolic reprogramming in intestinal stem cells can promote the risk of cancer initiation in the setting of diet-induced obesity. This paper from Marcia Hages's group, led by Dr. Rectal, who's now professor at MIT, really focused on interactions between colon epithelial cells, colon cancer epithelial cells, and the tumor microenvironment. So it's now widely recognized that the tumor microenvironment, particularly T cells, play an essential role in modifying the progression of cancers. And so CD8 T cells are cytotoxic, and they play an important role in controlling tumor growth in the non-obese state. And so what this group showed is that in the setting of a high-fat diet, diet-induced obesity, that this metabolic reprogramming in colon cancer cells, downregulation of this gene called PHD3. And what that does is that it inhibits CD8 T cell function. So now in obesity, you've got impaired anti-tumor T cells, cytotoxic T cells, and that allows the cancers to grow. I think this is an important point because immunotherapies are really the big discovery in cancer therapy over the last 10 years. And this suggests that the immune system plays a really important role in cancer progression, and that impairment of the tumor microenvironment and T cell function plays an important role in allowing and promoting tumor growth in the setting of diet-induced obesity. Another paper I want to highlight is this work by Samir Bayaz, who's a fellow at Cold Spring Harbor. This is a project that I contributed to when we were together at MIT and afterwards. So Samir is interested in understanding how intestinal epithelial cells play a role in antigen presentation and recruitment of T cells in the gut. And what he showed is that in a setting of a high-fat diet-induced obesity, that there's downregulation of MAC class 2, which is an important set of genes that are involved in antigen presentation. Traditionally, these were thought to predominantly be functional in dendritic cells, immune cells, but Samir showed, consistent with other recent papers, that MAC class 2 is highly expressed in the intestinal stem cells. And when there's downregulation of MAC class 2, there's decreased immune surveillance, and then that can then promote tumor formation. And then mechanistically, Samir and myself and our collaborators showed that changes in the microbiome, microbiome diversity, can result in the setting of a high-fat diet, can result in the downregulation of MHC class 2. So this paper really highlights the interaction between stem cell-induced antigen presentation and immune function in the setting of diet-induced obesity. In terms of the microbiome, this paper just came out, I think, about a month ago. And I think it's very exciting because, number one, it supports prior studies showing that diet-induced obesity promotes colon cancer progression in mouse models. And what these scientists did is they performed stool transfer studies in germ-free mice to show that stools from mice with diet-induced obesity and colon cancer, that the microbes in those mice can then reproduce that phenotype and promote colon cancer growth in mice that don't have a microbiome. And so essentially showing that some component of the microbiome can be transferred from the mice with diet-induced obesity to promote colon cancer growth in other mice. And what they showed is that diet-induced obesity alters the microbiome in the gut, induces dysbiosis, lower diversity, changes in the composition of the microbes. This results in alteration of the micrometabolome. Potentially, although they didn't show this, potentially there may be metabolites produced by specific bacteria that then result in promotion of colorectal carcinogenesis. So this paper adds to a growing body of evidence that the gut microbiome plays a really important role in our health and potentially in our cancer risk. I think this would be a ripe area for future study to understand how the microbiome is altered in different ethnic groups and clinically in obese versus lean patients. I just want to close by mentioning some ongoing work in my lab, not completed yet, but I think it's interesting enough to present today, led by Ellie Glennie, brilliant postdoctoral fellow in my lab, co-mentored by Stephen Hursting, who's at UNC Chapel Hill. So Ellie has analyzed adipocytes from mice and from patients, and she's shown that the adipocytes themselves, you're excluding immune cells and all the other cell types in fat tissue, secrete adipokines and cytokines. And so our next step is to then to understand how these adipokines and cytokines secreted by adipocytes might play a role in signaling to colon cancers. Next, she showed that adipocyte conditioned media can then promote proliferation in a colon cancer cell line, suggesting that some component of these cytokines that are secreted by adipocytes is promoting colon cancer growth. Next, what she did was give a high-fat diet-induced obesity to mice with AOM-induced colorectal carcinogenesis, and then she gave them an anti-inflammatory agent. Giving the anti-inflammatory agent reversed the effect of the high-fat diet in promoting colon cancer growth. This suggests that potentially some component of the fat that's inflammatory, like inflammatory cytokines, may be responsible for promoting colorectal carcinogenesis. So we did RNA-seq or global transcriptome profiling of these tumors, the obese mice versus the lean mice, and one gene stuck out called SFRP4. SFRP4 is a regulator of the Wnt signaling pathway, which promotes colorectal carcinogenesis. SFRP4 increased in the obese tumors, but then went back down in the obese mice that were treated with Silindex, suggesting that it may be an inflammatory marker or in response to inflammatory markers in the setting of obesity. In fact, on immunofluorescence, SFRP4 is increased. So ongoing studies in the lab, led by Ellie, are studying mechanisms by which SFRP4 might promote colorectal carcinogenesis. I'd like to thank you for your attention and acknowledge the members of my lab, particularly Ellie Glennie, who led the work that I closed with, as well as collaborators Stephen Hursting, Nellie Ulrich, and my funding sources. Thank you for your attention. I look forward to answering questions and discussing these topics with all of you. Thank you.
Thank you, Dr. Roper. As a reminder to all participants, if you can please place your questions for our panelists into the chat, and we will take your questions after the final presenter. I'd like to move to our second presenter now and provide a brief introduction, Dr. Christine Malenti. Dr. Malenti received her undergraduate training in human nutrition from Ohio State University, her MPH in public health nutrition from the University of Minnesota School of Public Health, her PhD in epidemiology from the University of Arizona College of Public Health, and completed postdoctoral fellowship training in cancer epidemiology at Columbia University Medical Center. Currently, Dr. Malenti is a cancer epidemiologist and assistant professor in the Departments of Occupational Medicine, Epidemiology and Prevention, and the Department of Pediatrics at the Zucker School of Medicine at Hofstra University and Northwell Health. And Dr. Malenti will be presenting her talk entitled Women and Colorectal Cancer Prevention. The time is now.
Hi, everyone. Thank you very much for your kind introduction. It's such a wonderful opportunity to be here today and to present a topic that often is overlooked and somewhat ignored in the clinical setting, and there's very low awareness in many ways among the disparities of women in colorectal cancer. And I'll be talking a little bit about women in colorectal cancer from the standpoint of a gender disparity, and also within women in colorectal cancer, some of the racial and ethnic disparities that exist. So a brief outline, I'll go through the burden of disease in the clinical presentation, take you through some of the current statistics on women in colorectal cancer, and then highlight just a few of the risk factors, chemo prevention, screening, and I'll end with a call to action and some of the work that we're doing currently at Northwell to try to mitigate the incidence and mortality of this disease. So currently among women, colorectal cancer is the third most common and the third leading cause of cancer death among women. And what's not always known is that the total number of colon and rectal deaths among women about equals the total number of ovarian and endometrial cancers combined. And for this reason, I'm really trying to, through our campaign and through our grants, is to highlight the importance of focusing our efforts specifically on women and colorectal cancer prevention. And so when we talk about the incidence, I know this is going to probably be repeated in the next few talks, but it's very important to see and note, not only is the increase that we're seeing among men and women, both in the ages under 49, and incidence rates are comparable among women under 45 years of age. We see that in older ages, the incidence and mortality is a little bit higher among males. But most strikingly, in this next figure, where we see the figure of men and women, but we'll focus specifically on women between the ages of 50 and 64. There's been dramatic declines in colorectal cancer, as was previously mentioned. But what's not always highlighted is this flattening of the curve, where we're seeing this in the last 5 years, where instead of these dramatic declines in incidence and mortality, we're starting to see this taper off and seeing increases at 1% per year over the last 5 years. And when we talk about the birth cohort effect and the phenomenon of how that works, this is a little bit worrisome because it seems like those younger ages may also be starting to impact what we're seeing in the older age groups. And most importantly, there's an increase in colorectal cancer incidence and mortality among those 50 to 55, because at 50, and I know the recommendations are now 45, but at 50, when it was that age, people were not complying with colonoscopy right at that age period. So we are seeing an increase in these older ages, which needs to be addressed, especially among women. And again, mortality is still declining, but it's declining more slowly now. And when we look at incidence and mortality in total among women, even though we saw declines over the last several years prior to this increase, the declines have always been slower among women than among men. And this is just a quick graph to show, again, that the female incidence and mortality is a little bit lower among women. But if you notice that we're starting to close in on the gap between men and women. You know, many years ago, many decades ago, they were about neck and neck, but now we're starting to see a closing of this gap again between men and women. And cumulative incidence among men and women is about equal at 4.3 versus 4.1%. And oftentimes, and there's data to show this, women perceive colorectal cancer as a male disease. They therefore feel less susceptible. And when you hear information like this reported, women also feel that their chance of getting colorectal cancer is less. But we really have to stay focused on this being the third leading cause of cancer death. With in this year alone, 3 women dying every single hour of this disease in 2022. We recently ran the SEER data for women only to really try to tease out what these data look like. And among women, we see that the majority of cases are 55 years in age and over. But again, there's this concerning proportion under 55, which is not so uncommon anymore. The mean age at diagnosis among women is actually going down. It's now at 66.9 years. When we look at stage at diagnosis, we know that the majority of female cases are actually diagnosed in the regional and distal stages when there was already spread of disease through the wall of the colon or the rectum. It may have invaded nearby tissue or nearby lymph nodes. And with colorectal cancer being one of the most preventable cancers, this is an unacceptable statistic that we are currently dealing with here in the United States. We know that stage at diagnosis is highly correlated to survival. So when you have a large proportion of women being diagnosed at later stages, that equals lower survival. And so we know that the regional and distant stages can have a survival, a 5-year survival of as low as 15%. But when diagnosed in the earliest stages, obviously we see much greater survivals. One of the problems is that often patients have no symptoms at all when colorectal cancer is in its earliest stages. So when symptoms are present, and these are some of the differences where we see between men and women. When symptoms are present, we see a change in bowel habits, rectal bleeding, rectal mass, or abdominal mass. But what's specific about women and what needs to be highlighted is that some of these women are presenting with iron deficiency anemia, fatigue, loss of energy, abdominal pain and cramps. And a lot of these are misinterpreted and considered menstrual cycle findings. And what we've seen through many reports that have been conducted on early onset colorectal cancer, Dr. Siebel is going to go into this in much more depth, but just for women especially, and another reason why this needs to be brought to the forefront is that a lot of women who are being diagnosed actually saw several different physicians prior to their diagnosis. They were told that they had some conditions such as hemorrhoids or irritable bowel or anemia. And so these are areas that will help us in terms of awareness to try to mitigate this disease among women. Now, I want to turn to some of the biological features and where there are very specific and significant disparities between men and women. So one of the things that's interesting that has been found in the literature and probably over 20 years ago, it's been shown that the colon actually has two distinct regions, which have different characteristics related to their molecular profile, the pathologic and molecular profile, and in a different landscape. And we see that proximal colon cancer is more common in females compared to males. And when we look at the embryologic origin of these two different regions of the colon, the origins are different. They have different vascular structures, different nervous supplies. One from the ascending colon and the right-sided colon is associated and comes from the midgut. The descending colon or the distal colon comes from the hindgut. So there are very different regions of the colon, and women are really falling into this right-sided colon area. And when we look at the genetic changes among women, where the right-sided colon is really associated with microsatellite instability, BRAF mutations, and a few other genetic profiles that are different from the left-sided. And not only is this important when we just look at how this disease presents, but it has implications for survival. It has implications for treatment. And quite frankly, the disparities among men and women still require much greater evaluation to really understand what is driving this disease among women. In terms of survival, there's evidence to show that among patients with localized disease, there is a survival advantage of women at all ages. But when you start looking at more advanced disease, the survival advantage is really limited to women below 65. And then among patients with advanced disease, older women, 75 years and older, show significantly worse survival than men. So you'll start to see with what I'm going to present here going forward is that there is a particular increased risk among older women. And this also needs to be addressed, especially when we start thinking about the risk factors for colorectal cancer among women. First of all, the most important risk factor is age. And age is and women are representing an increasingly greater proportion of the population at older ages. So as our population continues to grow, women will continue to outnumber men by 2060. And again, this disease, as we're characterizing it among women, really shows a shift in risk among older women compared to younger women, even though we don't want to ignore the rising incidence in the younger group. But the older group is also extremely important. And as the population ages, this is really going to become a very important public health issue to address. When we look at, when we look at race and ethnicity, Black women experience the highest rate. Non-Hispanic Black women have the highest risk of colorectal cancer among women, and they are reaching rates similar to the white male population. And by 2050, white females will no longer be the majority in the United States. It's predicted that the population will include a lot more diversity. And as Dr. Tufson was mentioning in the beginning, when we talk about socioeconomic status, and we see this shift of more ethnic and lower socioeconomic disadvantaged women in this younger group, we're going to see more women living below the poverty level. We're going to see more women experiencing food insecurity. And this will only magnify the disparities among this population. So the reason the talk is titled "The Time Is Now" is because we really want to focus on getting prevention strategies into place for women so that we can carry this forward into the future and make a difference. Another risk factor for women in colorectal cancer, which is obviously universal, are adenomas. And the two different pathways of adenoma development, meaning the conventional pathway and the sessile serrated polyp pathway, or the serrated pathway. Women really fall into the greatest risk of serrated lesions. But when we look at adenoma development, women reach equivalent levels of adenomas, colorectal cancer, and colorectal cancer mortality as men, but it occurs nearly a decade later in life than their male counterparts. So again, as our women are aging, they're going to see a greater increase in risk and up to the same levels as we're seeing in males. And this disparity has many different questions associated with it. There's the hormonal factors. There's the whole dietary piece, which has a lot of different and inconsistent results. The biologic variation, as I mentioned earlier, and then the prevalence of the colorectal cancer precursors, which I wanted to mention now, which are the sessile serrated lesions, which are more common among men. And these lesions are more prevalent in the proximal colon, and they're harder to see. They're flat lesions that are often missed. And we see among women higher interval cancers following colonoscopy. And interval cancers are cancers that occur sometime after the screening tests that were potentially missed. When we talk about advanced colorectal polyps, so these are big polyps, centimeter or more, any village histology, any high-grade dysplasia. And these advanced colorectal polyps are quite prevalent. There are approximately 19 million colonoscopies performed in the United States every year. And about 2 to 9% of those are these advanced lesions that women are at higher risk for. And what we're seeing, though, specifically, is that these rates of advanced lesions are highest among Black women compared to women of other ethnicities. And a large study looking at 85,000 Black and white women really uncovered and emphasized this a bit more, showing that Black women have a 60% greater risk of advanced lesions compared to white women, and a higher prevalence of large proximal polyps. So this is another area, of course, of great concern and requires addressing. The other risk factor is history of advanced polyps. Dr. Siebel is going to go into this in more depth. But again, we want women to understand their family history of advanced polyps because it increases their risk for colorectal cancer. Lifestyle factors, there's a couple different varying results between men and women with smoking, with obesity, with diet. So not all risk factors are created equal. And because of these differing landscapes in the colon, therefore, there may be different risk factors that impact a person's susceptibility to developing cancer in that particular part of the colon. So development of sessile serrated polyps, proximal colorectal cancer, and colorectal cancer mortality are all associated with smoking, and greater susceptibility has been shown among female smokers compared to men. And I mentioned here in this photo just that the induction period for smoking-related colorectal cancer took several decades. So at one point, it was always believed that smoking was associated with or a male colorectal cancer. But once women really started to smoke early on in the late 50s and 60s, we then started to see the effects of that exposure. And now finding that it's actually a little more a dangerous exposure for women compared to men. And we also see that smoking may exert its greater effect in colorectal cancer in women via the serrated pathway. Obesity is extremely complex. I'm not going to get into this, but obesity has really modified the menopausal status among women. There's some indication that premenopausal women are protected and postmenopausal women are at higher risk. So there's a hormonal component. When we see the use of HRT, it may mitigate some of that risk. But again, this is another area that hasn't been fully evaluated. Diet is a very important piece of this puzzle. We know that about 55 to 70% of colorectal cancers can be associated with diet and dietary intake. The differences between men and women with diet are quite vast. One of the only nutrients that has really shown a stronger association among women is vitamin D. Chemo prevention is a very broad area, obviously, and although we know that the reduction in mortality from screening is extremely significant, we also know that chemo prevention can also play a role in mitigating the initiation, promotion, and progression of this disease. And there are a number of chemopreventive agents, aspirin being one of the first and most well-known, but also hormone replacement therapy, folic acid, fiber, calcium, vitamin D. There's a lot of inconsistency in these results, and therefore it makes it very difficult to create prevention recommendations. But what I'm urging is for a way to look at some of the cohort data and try and look at some stratified analyses to see where these are really pulling out for women. I'm going to touch on screening very briefly. We know that the USPSTF changed their guidelines in May to 45 following ACS and the other gastroenterologic and oncologic societies. But what I really want to point out here is that in this age, 76 to 85 years of age, the recommendations that clinicians selectively offer screening for their patients is really sort of left up to the clinician. And so this is an area also of potential awareness, not only among patients, but among providers, to make sure that we're talking to older women early, not when they turn 76, but when they're in their later stages, to start thinking about colorectal cancer and their increased risk. We know that screening intake is lower, uptake is lower among women. And we know that the left-sided tumors or polyps are a lot easier to find, as you'll see here on the right, among men. And here is a colorectal lesion, a colorectal cancer on the right-sided of the colon, and it's very difficult to see. And so this is why this is a very important area of discovery to understand how we can further improve screening, early detection for women. We just recently developed a polyp brief to help our providers screen their patients early. And I just have a couple of clinical scenarios. I'll go through one and can provide these afterward. But just in terms of the clinical setting, how do you approach and do we help to mitigate some of the disparities among women? Well, the first is really to educate ourselves on what the screening recommendations are in our female population. So here is an asymptomatic 39-year-old African-American female. Her father had an advanced polyp, a large polyp at age 67. When would you tell this patient to come in for screening? And so the natural course would be well, if this patient was having a colonoscopy, the natural course would be to counsel them on when they should come back for surveillance. But in this case, we want to take a proactive approach and ask this patient to not only tell her siblings to get screened, but she herself should be screened at the age of 40. And Dr. Siebel is going to get into this more. There's a few differences in screening that are often overlooked in access to screening. The quality of colonoscopy is a little bit different in women compared to men. Like I said, there's a 34% increased risk of an interval colorectal cancer compared to men. They're less likely to have a complete exam where they go all the way to the cecum. And women have longer colons than men. It's in the transverse colon, and therefore may make it more difficult to detect polyps. And the performance of colonoscopy is more difficult in women who've had any kind of abdominal surgery. And then there's a whole host of factors related to perception of the screening test, which are different among women compared to men. Embarrassment, fear of the test, anxiety, preference for female endoscopists, and increasing body weight may inversely associate with a lower screening adherence. So here's the call to action. I'm just going to wrap up here at the end to say that we really need to improve patient and provider awareness regarding the disparities between women and men when it comes to colorectal cancer, and not only women in general, but among non-Hispanic Black women as well. Optimize post-colonoscopy communication with patients and their close relatives, and then find ways that we can develop a tailored prevention program for women, not only in this older population, which is obviously extremely important as the population ages, but also to try and tie in very specific female messaging with the younger population as well. At Northwell, we have developed a team and just received a grant to really change the way we're seeing female patients in colorectal cancer at Northwell. We developed a fast-track colonoscopy program. We have a simplified referral coordination program. We've developed a number of patient videos, risk assessment surveys, different education materials, and a website to really try and really change the impact of this just a little bit. We also created a patient video. It's a minute long. I don't know if I have time. It's already 9:29. I'll just keep going and I can share the video with everyone later. And so just to summarize, why now are we interested in women in colorectal cancer? Well, the lifetime cumulative risk is similar among men and women. There are substantial differences in risk factors, tumor biology, and cancer prevention services. And quite honestly, I didn't really even delve into some of the differences that have already been published, but there's a lot of work to do in this area as well to really understand how we can mitigate this disease among women. And colorectal cancer incidence is increasing under 50, and a detailed analysis on gender disparities has not been fully evaluated. And that's really where we need to put our time. And so I just wanted to thank our entire team. Not only is this a multidisciplinary, it's a multi-departmental team that we've put together to tackle this problem, to put colorectal cancer among women in the spotlight, and to bring the attention that it deserves among our female population and among our providers. Thank you very much for your time. I greatly appreciate it. I'll take any questions at the end, and happy to share the video at the end of this symposium today.
Thank you, Dr. Malenti. I'd like to now move to our next presenter, provide a brief introduction. Dr. Marissa Siebel received her medical degree from the St. George's University School of Medicine. She completed her internal medicine residency training at Maimonides Medical Center and completed her hematology and oncology fellowship at the University of Vermont. Currently, Dr. Siebel is a medical oncologist and assistant professor of medicine at the Zucker School of Medicine at Hofstra University and Northwell Health. And Dr. Siebel will be presenting her research entitled Early Onset Colorectal Cancer, Awareness and Prevention.
Thank you very much. Thank you, Dr. Camacho Rivera, for your kind introduction. Thank you to Dr. Martella Rooney for the invitation, to my colleagues today for your wonderful talks, and to all the prestigious members of this organization. It's an honor to be here. Today, I'll be speaking about early onset colorectal cancer. I'll first cover epidemiology and risk factors, followed by clinical outcomes, and then close with screening and prevention. So to begin, disparities are differences that occur across populations. Healthcare disparities are differences in access to medical facilities and services and variation in rates of disease occurrence and disabilities between population groups. They are defined by socioeconomic characteristics, including age and ethnicity, economic resources, and gender. What we know today is colorectal cancer is the third most commonly diagnosed cancer in the United States and the second leading cause of cancer death among men and women combined. When we speak of early onset colorectal cancer, we're speaking about patients that are younger than the age of 50. Colorectal cancer trends today, overall, we look at the majority of cases reflecting older age groups, and this tends to mask trends in young adults. In terms of the rate of colorectal cancer, we see that it has been steadily increasing in the particular age group of 20 to 39 since the mid-1980s, and since the mid-1990s, it's been steadily increasing in the age group of 40 to 54. This increase has been seen in about 51% of cases in this very young age group of 20 to 49-year-olds, again since 1994. And per the National Cancer Institute, this trend is expected to continue. When we talk about the median age of colorectal diagnosis, it used to be in the early 2000s around the age of 72, and today it is at age 66. Looking again on the right side of this screen to the 20 to 49-year-old group, what we see is a 55% increase in colorectal cancer in the 20 to 49-year-old age group. Again, we've been seeing this since 1995 in the United States. This age group 0 to 49 has had the steepest increase from 2012 to 2016, 2.2% per year increase in incidence. Whereas in age 50 to 64, we've seen only about a 1% per year increase. And when we look at age 65 plus, the incidence has decreased by 3.3% per year, very different numbers for each age cohort. So when we talk about this, we think about the birth cohort effect, which is a pattern of generations of age-specific individuals with a higher incidence, and they carry this elevated risk with them as they age. We see this across the globe universally, and this will continue if causal factors are not identified. Dr. Siebel published recently a very important quote that said, "It is therefore imperative to consider the possibility that early onset colorectal cancer may only be the beginning of an increase in colorectal cancer at all ages, and this will become evident as the current young population ages and reaches later stages of life. If epigenetic changes of drivers of risk continue, there's a significant possibility that future generations will also have these similar trends." So this speaks to our urgent need for research on the influence of these new highly prevalent early life exposures on colorectal cancer risk. We know major modifiable risk factors for colorectal cancer, and these are, just to review briefly, excess body weight, cigarette smoking, heavy alcohol consumption, high intake of red or processed meat, physical inactivity, and family history. Specifically, as mentioned by my colleague, Dr. Malenti, the risk of early onset colorectal cancer in US women was increased by 20%, and that's looking at every 5-unit increase in body mass index. We've seen this. We've also seen an increase by 69% for US women who are watching more than 14 hours of television per week. Associations have been reported recently between colorectal tumors and antibiotic use, as well as use of or eating of high fructose corn syrup. And this is likely mediated by the alteration and composition of gut microbiota. And what we also found was that uptake in colonoscopies has not been the reason to increase to explain these increased incidence rates. Looking at this graph on the left side, what we see is the younger cohort of patients aged 20 to 29 and 30 to 39, they have the steepest increase in incidence in both colon and rectal cancer. When we look at that age group again of under 50, 11% of colon cancer diagnoses in the blue line below are under the age of 50 in the United States, and 18% of rectal cancer diagnoses are under the age of 50. By the year 2030, it is predicted that in this 20 to 24-year-old age group, the colon cancer incidence will double and rise by about 90%. In the 35 to 49-year-old age group, the increase is projected at 28%. Looking at rectal cancer, the incidence is thought or projected to quadruple to approximately 120% and increase by only 46% again in that 35 to 49-year-old age group. A recent study based on cancer registry data from 47 states found that early onset colorectal cancer incidence is increasing among non-Hispanic whites in most states, and the most rapid pace of increase has been thought to be in the West. Looking at this diagram, or map, I should say, from 1995 to 2015, early onset colorectal cancer incidence rate actually increased by 57% in Colorado and 73% in Washington state. And what we see highlighted in the dark blue areas are areas like North Dakota and Iowa. These are identified as having the highest incidence of early onset colorectal cancer in the United States. Globally, we see outside of the US, the increase is seen as well. It's seen in many high-income countries, including Australia, Canada, Germany, and the UK. When we think about mortality, the effect is also seen in this early onset group of colorectal cancer patients, age less than 50. What we see is death rates increasing by about 1% per year since 2004 in the age less than 50 group. However, in age 50 to 64, we're seeing more of a rapid decline over the last few decades, and mortality is slowing. And in age 65 and older, the mortality decline is the steepest, with the slowing from 3.3% to 2.6%. What are the possible reasons for this? Well, patients and primary care physicians are shown to contribute to the delay. Young patients have been found to wait an average of 6 months before seeking care. Once they're evaluated, 15 to 50% of the time they experience primary care physician-related delays, and that would include maybe missed symptoms or initial misdiagnoses, which I'll get into further. Early onset colorectal cancer patients are unfortunately more likely to be diagnosed at a later stage because of these mishaps, at stage 3 and 4 most commonly. And this will affect, in all races, the trend to increase the mortality in this young age group, and has been shown. So when we look at clinical outcomes, I'd like to talk about a study of young onset colorectal cancer survey project that was recently published in, actually it was published in June 2018 by the Colorectal Cancer Alliance Group. And it really looked at this specific age population across the globe. They reviewed 1,622 responses from young onset colorectal cancer patients, survivors, and caregivers from 38 different countries. And here was the geographic distribution. In this study, we saw that the majority of survey participants, 57% in fact, said they were diagnosed between the ages of 40 and 50, as you see here. The most common symptoms mentioned today tend to be constipation, blood and stool, bloating, rectal bleeding, and diarrhea. In the bottom of this diagram, 26% of patients reported one symptom, while 56% reporting having at least 3 symptoms. Looking at the findings from this study, they were very interesting, and I'll report them now. 71% of patients were diagnosed at a later stage, and this is the early onset colorectal cancer patients, stage 3 and 4. 67% had seen at least 2 physicians prior to a correct diagnosis. 41% waited at least 6 months after experiencing symptoms before speaking to a physician. In terms of family history, 72% reported no family history of colorectal cancer, only 28% having a family history of colorectal cancer. And in terms of clinical trials, 62% of these young patients were not aware of clinical trials, having only 8% participate in clinical trials. These pie diagrams show that many patients in this age group saw multiple physicians prior to diagnosis. On the left, we see that most patients indicated they had to see at least 2 physicians, and in some cases, more than 4 different physicians prior to getting a diagnosis of colorectal cancer. What we also found was colonoscopy was really referred by primary care physicians, with a greater percentage of primary care physicians referring as the years have gone by. In 2018, 44% versus 35% in 2017. Initial misdiagnoses, unfortunately, were common in this young age group, with the most common misdiagnosis being hemorrhoids, followed by irritable bowel syndrome or irritable bowel disease. Many participants said they were diagnosed with many other ailments, including ulcerative colitis, gastric disorders, gallbladder, gluten allergy, celiac disease, UTIs, or even heartburn. They had a lengthy duration of symptoms before seeing a physician. Only 37% of survey participants on the left side here reported that they reached out to their doctors in less than 3 months to talk about their symptoms. 1 out of 5 waited more than 1 year to seek a doctor for their symptoms. And so what this results in figure 5 on the right is that we see a greater degree of young patients being diagnosed at a later stage, particularly stage 3 and 4. In this diagram, 46% were diagnosed with stage 3 and a quarter were diagnosed, or 25% with stage 4 from this study. Quality of life findings were extremely interesting in this age group and different than the trends that we see in colorectal cancer among all the age distributions. So specifically in the young cohort, what we see is 85% of patients experienced anxiety or depression during or after treatment, and for different reasons. 55% sought treatment for anxiety and depression. 80% of the patients had children under the age of 18 when diagnosed, and that's a significant finding. 64% said a medical professional did not even talk to them about fertility preservation during diagnosis or treatment, again, adding to this anxiety and depression. 61% did not have a healthcare proxy or medical directive in place, again, different from our older patients. 64% took a leave of absence or quit a job or schooling because of their diagnosis, and that led to 62% of patients experiencing financial difficulties. So what this study really showed was an acute need to raise awareness of young onset colorectal cancer, both among the general population and among the primary care physicians and other physicians who often see patients first with these symptoms. It's so important to promptly evaluate patients with blood in the stool, rectal bleeding, change in bowel habits, abdominal discomfort, bloating, nausea, vomiting, anemia, unexplained weight loss, fatigue, and weakness. Referral of young average risk symptomatic patients for endoscopic workups needs to be thought about much more prominently and start conversations and education earlier about the family history of colorectal cancer diagnosis. And then what we're going to talk about and what Dr. Malenti spoke about, which is the importance of knowing your family history of even adenomatous polyps. Are they advanced polyps? Are they serrated? Are they villous? And those are underlying risk factors for future disease. So now that leads me into screening and prevention. Dr. Jennifer Kolb and Dr. Malenti have published and spoke about response to rising incidence of early onset colorectal cancer. Many professional societies have had to update their screening guidelines because the average risk that we mentioned in individuals is now prompted us to screen patients not at age 50, but at age 45 for those average risk patients, not the high risk that we'll get into. So the American Cancer Society, the US Preventative Services Task Force, the American College of Gastroenterology, the National Comprehensive Cancer Network, and finally the US Multi-Society Task Force have all moved their age of screening to age 45. When we look at these patients who now present with colonoscopy findings of advanced adenomas, it's important to know the sequence that happens, which is normal epithelium taking on changes from environmental mutagens, hereditary mutations, which lead to dysplastic lesions, adenomas, and finally metastatic cancer. About 16% of cases occur in individuals with a hereditary condition like Lynch syndrome. About 14% of cases have a family history of colorectal cancer. But what's important here is that there's a large portion of early onset colorectal cancer cases who have a family history of advanced adenomas that warrant earlier screening. And when you think about it, we all have family members who have colonoscopies and they'll tell you that they were normal, but really, do we know what our family's adenomas really look like? Are they high risk? Are they this high-grade dysplasia? And this is very important to know your family members' colonoscopy reports and know what your risk is. And the risk for family members of patients with advanced adenomas can lead to a 2 to 4-fold increased risk of developing colorectal cancer. When we look at the relative risk with high-grade dysplasia, it's 20. And so this has caused an adjustment of the guidelines for the high-risk individuals, not the average risk, but specifically what's important to know is that first-degree relatives with advanced adenomas are weighted the same as first-degree relatives with colorectal cancer. And the yields of colonoscopy screening in a patient whose first-degree relative has an advanced adenoma is substantially increased. The communication is so important for polyp findings, and it's often not shared with first-degree relatives as mentioned, and individuals at high risk are not aware that they should be screened actually at age 40 or 10 years prior to the relative's diagnosis. So we see this both in the US MSTF guidelines and the NCCN guidelines. And if you specifically look at this, you see advanced adenoma in 2 first-degree relatives or advanced adenoma in 1 first-degree relative less than 60 years old. The recommendation in this high-risk group is to begin screening at age 40 or 10 years before the age of diagnosis. Even with an advanced adenoma in 1 first-degree relative at age greater than 60, screening should begin at age 40. And the NCCN concurs with this finding. So what is necessary both across the board in the United States and exists in many locations is a center that will focus on early onset colorectal cancer patients. There is a unique need, as I mentioned, for these younger patients, specifically for fertility concerns, sexual health, diet and nutrition, exercise, psychological support, and social work. A program coordinator is necessary, a multidisciplinary team to review each case in an expedited way, a team of surgeons, radiation and medical oncologists, radiologists, and they should be dedicated solely to these young adult patients. Genetic evaluation is so important to determine whether the cancer has a hereditary predisposition. Again, looking at patients' family history of not only colorectal cancer, but their colonoscopy reports from family members and adenoma history. Young adult focused resources are necessary. Convenient colonoscopy screening times for these young patients who are often working and juggling family needs. Integrative therapies such as acupuncture, mindfulness, meditation, massage, exercise, nutritional consults. Sexual health counseling, very important, as well as fertility preservation options need to be discussed. Psychological support, advice on how to talk to children, and peer support to connect cancer patients with survivors and caregivers. These needs are very different than their older counterparts. So for future research, we need to understand the drivers of early onset colorectal cancer and study known contributors such as family history, advanced polyps, and hereditary syndromes. Current areas of study by epidemiologists include areas such as nitrates in drinking water, especially well water in North Dakota. The group Fight Colorectal Cancer has prioritized studying risk factors, including gene-environment interactions, microbiome, diet, and antibiotic use. And in summary, I'd like to just say again that the rate of early onset colorectal cancer, unfortunately, is increasing for 2 decades for many reasons. Steepest increase is noted in the young age, advanced stage of diagnosis, rectal cancer more so than colon cancer, non-Hispanic white patients, and mostly in the Western states. Screening is recommended to begin at age 45 for average risk patients and to begin at age 40 for high-risk patients with family history or colorectal cancer or colorectal polyps. Diagnosis should not be delayed in young patients who present with these symptoms that are characteristic of regular disease, such as abdominal pain, rectal bleeding, and changes in bowel habit, and need to be taken seriously right from the get-go. Patients with early onset colorectal cancer are treated both in the adjuvant and metastatic setting, just as their older counterparts are, and need to be seen and gotten in early. Fertility, pregnancy, sexual health, financial toxicity, and long-term survivorship are unique issues in managing early onset colorectal cancer. And there is a priority to screen early for this disease and for colorectal polyps in young patients that will be necessary for prevention. Finally, the best treatment for early onset colorectal cancer is prevention. Thank you.
Thank you, Dr. Siebel. I'd like to briefly introduce our last presenter in this session. Dr. Richard Whalen is the System Chief for Colorectal Cancer Surgery in the Northwell Health System. He's maintained a basic science and clinical colorectal cancer research unit for over 20 years. His main research interests are in minimally invasive methods, the systemic ramifications of colorectal resection, and the development of anti-cancer treatments to be used in the perioperative period. And he'll be presenting his talk on surgical treatment of colorectal cancer and the impact of race and socioeconomic factors on the treatment given and outcomes.
Anyway, as a surgeon, I'm going to talk about the first what's gone on in the world of colorectal surgery in terms of the treatment of colorectal cancer, and then get into the disparity issues and how that affects surgery. These are my disclosures. To begin with, so what's changed in the last 20 years or so is that the approach to colorectal cancer has changed dramatically. The majority of patients now in the US are getting treated using minimally invasive methods, which was not the case even 10 years ago. It was under 30% if you looked at the large databases that we have. And now it's well over 65% in most places. The types of minimally invasive methods have also changed over the years. And started out with just laparoscopic or hand-assisted, and now there's in the U.S. especially a growing proportion of cases being done using robotic methods, and there's also other minimally invasive splinter methods that are out there. And these changes are not all based on randomized controlled trials, but kind of the patient and doctor preference on this. But clearly, the majority of cases are now done using minimally invasive methods. The breakdown of minimally invasive method use in low socioeconomic groups or different race groups is somewhat different, though, as per some studies. Again, although in the rest of the world, the use of robotics instruments and tools are limited, in the US, it is growing. And of importance is to note that the actual cancer outcome results for the both open and minimally invasive methods thus far are similar. And currently, what method you use is based on the surgeon preference and the patient's choice. As far as the scope of what's being done resection-wise these days, it's not any different for colon cancer. It's the same as it's been. You need to get the tumor with a margin on either side of that, and you need to get at least 12 lymph nodes to get a good sampling of those. And the goal is, of course, to do an anastomosis and avoid a colostomy, although they're used when necessary, although not so often for colon cancers. Where there's been a huge change over the last 15 years, 20 years, is the fact that the neoadjuvant treatment for colon cancer, which was something that was not done that often, is now more commonly being done, and also adjuvant treatment choices are much greater. We have robust chemotherapy regimens, and also with possible addition of Avastin or cetuximab in terms of monoclonals to enhance those treatments. Also, the development and introduction of immunotherapy in terms of, which is very effective for MSI high tumors, is also changing the basic way that these tumors are treated, and that data is still being gathered, but real change in the last 10 years. Finally, neoadjuvant chemotherapy for stage 4 patients who do not have obstruction or evidence of severe bleeding is now standard of care. Whereas when I was a resident, which is a long while back, you could many times the surgeon would debulk the patient's overall disease volume by doing a colectomy and then delaying the chemotherapy start, which turns out to be pretty much a bad idea. So now this is another basic change, the idea of avoiding surgery altogether unless you need to in a patient with stage 4 disease. Another change we're now seeing being used in many places, and we'll see an increasing use of this, is the circulating tumor DNA surveillance. This is where patients are tested every 3 months, although the interval may vary, different programs, but the idea is to look for fragments of tumor DNA in the bloodstream in patients who had a tumor and it was resected, and when they go to a status when there is no circulating tumor DNA, that's ideally what happens. But the ability to detect the circulating tumor DNA is very powerful. A bit of information. It's an incredibly sensitive means of detecting tumor recurrences, and it's far better than any of our other traditional markers like CEA, CA19-9, for just totally much more sensitive. And it has the potential to guide adjuvant treatment, although at this time the results are not yet actionable as regards to selecting adjuvant treatment decisions or helping you make those. But the promise of this is that the presence of ctDNA postoperatively is highly predictive of recurrence regardless of stage. And the promise is that we could identify stage 1 and 2 patients who should get adjuvant treatment, who at this point in time are not getting it based on their stage of disease. And the converse is also true, that the absence of ctDNA postoperatively is associated with a very low recurrence rate. So you might be able to identify patients who have stage 3 disease who do not need to get the chemotherapy, in which case you'd save them the morbidity and problems associated with that, as well as the cost of that. Although at this point, again, these are not actionable items. One of the big changes in the rectal cancer world is the fact that in the U.S. over the last 5 or 6 years, there's been a real push for multidisciplinary tumor boards in the U.S., and this has been pushed by the American Society of Colorectal Surgeons, and also now in conjunction with the American College of Surgeons, COC centers, has developed a national accreditation program for rectal cancer. And this is something that every hospital wants to be accredited in and be a part of, because it would assure patients a certain standard of workup and care that would hopefully attract patients to the hospital. And it's one of the toughest programs to get accredited in. Very difficult to obtain this accreditation. It requires a mandatory data coordinator for the tumor board, and most of these are full-time employees, as well as tumor board directors, and also identified people in each of the specialties which need to be present at each of the tumor board meetings. The typical tumor board makeup: medical and radiation oncology, surgery, pathology, radiology, and GI. At this point, which was not the case even 10 years ago, most rectal cancer cases are being presented to tumor boards and treatment recommendations are made. And this is independent of there's no thing for this. Patients at a given hospital, all of them will undergo this type of evaluation. And also, we're also using these venues to present challenging colon cancer cases as well. And so I think the quality of care has really risen, notably in the US. It is 20 years ago, the rate of local recurrence for rectal cancers ranged wildly from 2 or 3% to 30%. And now we're seeing that the results are improving. And also the percentage of patients who are being offered getting neoadjuvant treatment is also increased. The workup that's mandated for this tumor board is colonoscopy and biopsy, but importantly, review of all outside pathology by in-hospital pathologists, standard tumor markers, CT scans of chest, abdomen, and pelvis. 10 years ago, the chest was not uniform at all sites, and also a mandatory MRI of the pelvis with rectal protocol. And in this program, you need to present each patient before treatment is given, to give a treatment recommendation after the workup has been done. And then also, if the patients went to neoadjuvant treatment, they get re-imaged and re-examined and then presented again following that treatment. And a decision or recommendation, I should say, made as to whether surgery is recommended, what type of surgery, or whether the patient might be a candidate for what's called watch and wait, which I will go into that in a moment. And finally, there's a third presentation that post-surgery, where the final pathology results are given and final treatment recommendations are made. This is a huge shift in the way this has been done in the US, which is a real improvement. And as far as neoadjuvant treatment, 30 years ago, the majority of patients did not get neoadjuvant treatment for rectal cancer. And now the good majority of them do. And that's based on T stage and also on a nodal status in the mesorectum, and also possible presence of locally advanced disease or out of boundary lymph node involvement. The treatments that are being given, of course, is radiation. And in the US, the long course, which is 5 weeks, combined with 5FU, most commonly now is capecitabine, is the most commonly used treatment. But short course, which is just 5 days of treatment of radiation alone, is also gaining in popularity and is an equivalent biologic effect. Systemic chemotherapy has also become something that is now being given fairly commonly to patients with locally advanced disease, certainly. And the idea is to combine between 4 and 8 cycles of chemotherapy, which can be given either before chemoradiotherapy or after. And by doing this, what's been noted is that the rate of complete response, where the tumor has gone away ostensibly, and MRI shows no evidence of residual disease. This has gone with chemo and radiation alone. This complete response rate is 15%, but with TNT, which is total neoadjuvant therapy, combining the two together, systemic chemo and the RT chemo, the rate rises to 30%. The criteria for this, we won't go into. It's not easy to determine a complete response, and there's lots of controversy. But the point is that the neoadjuvant treatment has become a keystone for the treatment of rectal cancer. Now, for patients that are complete responders, it's also become clear that a percentage of these may not need to have surgery done at all, which is completely out of the box thinking for patients with adenocarcinoma of the rectum, as opposed to anal cancer. And for these patients, if they've determined to be a complete responder, they do not get rectal surgery. Or if they opt for this, they may choose to just be followed very carefully. They get examined by their doctors every 3 months, get CEA testing at that interval. And we'd also add in now the ctDNA as well. And then MRI of the pelvis done every 6 months, and tumor board presentations at 6 months, which is what we're recommending at Northwell as we move forward. The recurrence rates are quite high, but about almost half the patients may be able to avoid radical surgery, which is a huge shift in the way these are treated. And these operations are not small operations. These rectal cancer operations have a high morbidity and a quality of life associated changes as well. As far as what surgery is done for rectal cancer, surgery for the last 30 years, we've been taught to do total mesorectal excision, which is to make sure that the entire mesorectal envelope is excised with the tumor, that we immobilize all the way to the floor of the pelvis, and to try to obtain a 5-centimeter margin of mesenteric bowel. This was not the case years ago. We shot for 2-centimeter margins, and we cone in on our specimens, and we would have a much higher local recurrence rate that way. And anastomosis are still done with diversion if necessary. And both MIS and open methods are used. In the US, robotic methods are being used much more often for these cases. It's also combined perineal and transabdominal approaches that are splinter methods that are also have merits to them as well. Finally, for very small early lesions, transanal local excision of a full thickness disc is also an option after staging, and one can add pelvic RT to that as well. Now, as far as the disparity part of this, first of all, is colorectal cancer in each race similar? Are the genetic profiles of the tumors in the different race groups similar? Are there subsets of patients in each race which have unique genetic characteristics, or a different proportion of the various subtypes? This is being addressed at Northwell and Cold Spring Harbor by several investigators. Dr. Jeffrey Boyd, who's the head of genetics and also the head of our biorepository, is looking into this question in terms of profiling tumors from African Americans and also Caucasian patients to see if there are differences. Dr. Samir Baez, Cold Spring Harbor, is doing the same. And this is important for us to understand. This might account for some differences between them, although we know there are many, many other reasons why we see worse outcomes in African American groups and also in low socioeconomic groups. But it's important for us to consider this, that we need to look for that, because the treatment may be different for patients in a certain race if they have a certain subtype of tumor that we're not aware of at this time. Now, as far as the data, that's clear data that the overall survival outcome for African American patients versus Caucasian patients is generally worse. And there's a lot. I've just selected out a few articles, but there's much data that shows the same. And the same is true for low socioeconomic status as well. And this applies to both the race of screening, the stage of presentation, the percentage of patients that get to surgery at all, and also outcomes, and in some cases even adjuvant treatment rates as well. Now, how can race and socioeconomic status affect things? Well, obviously, if you have limited access to screening and diagnosis or less awareness of the problem, then of course that will result in a different stage distribution, with a higher percentage coming in with stage 3 and 4 disease. Also, what is the access at different hospitals to chemotherapy and radiotherapy access? Are there differences there? And is the surgical treatment actually any different? Although the actual operation done may not be different, your options surgically may be different based on stage of presentation and other race or socioeconomic related factors. Surgically, the one thing that's important for surgeons is whether a case is done emergently or electively. Emergent cases for cancer have a clearly worse outcome, and both in terms of need for colostomy and R0 resection rate, but also overall outcome. And also, can you use minimally invasive methods, which we think it has clear benefits, although not survival benefits, and that can be shifted by this as well. When you adjust race in terms of income strata, you see that for the higher income strata that the differences between the races decrease, in some cases disappear. The other factors besides race or socioeconomic status is rural versus urban setting, also impacts the stage distribution and outcome as well. Now, how does this affect the treatment? Again, the type of surgery done may vary based on the stage of presentation and whether something is emergent or elective or not, the rate of stoma formation, again, the method used, minimally invasive versus other, and whether in fact you can get to surgery at all. And for rectal cancer, it's even easier to see the differences there, because again, although now we're seeing almost all patients, at least in the Northwell system, I'm sure at the downstate system as well, percentage of patients getting presented, regardless of race and socioeconomic status, is much higher. That has been an issue in the past. And again, whether these factors influence the percentage of patients getting neoadjuvant treatment, the complete response rate, and also sphincter saving surgery, which is important for this as well, and the rates of adjuvant treatment as well. And the obvious ripple effect, if you have patients coming in later, and if they have more comorbidities, because that's the other thing, is that African American subgroups and also lower socioeconomic groups tend to have more comorbidities, and many of them untreated. And these things all lead to worse outcomes in terms of surgery as well. We've seen that there's less minimally invasive procedures, more stomas, and a higher morbidity and mortality. The other thing is does each hospital, are they equal in terms of the surgical methods that are available at each hospital? And first of all, is there a MDTP, and are there colorectal specialists? Is there a robot in the hospital? Are there minimally invasive towers that are present? Are there some of the advanced transanalocal methods available? And also the very devices that are stocked in the hospital may differ in terms of staplers, bowel viability assessment tools and systems, and endoscopic capabilities. So these are all things that may be different. And in fact, one study that looked at minority serving hospitals versus non-minority serving hospitals found that in fact that the African American race and treatment at one of these hospitals were associated with a lower chance of receiving standard of care for rectal cancer. And even when they adjusted for the lower standard of care, that African-American patients had a significantly higher risk of mortality. Also interesting, how about just getting to surgery at all? If you don't get to surgery, that implies advanced disease for sure. And in a study that I'm showing here, African-Americans were less likely to undergo surgical resection, even when you controlled for age, comorbidities, location, and extent of tumor. And the results were similar in both teaching and non-teaching hospitals. And again, despite all this, in the end, again, shown the mortality difference against the African-American cohort. As far as the short-term out results, as a surgeon, we want to know leak rates and what is our mortality at 30 days. And in fact, in this national inpatient sample study that looked at a period between 2007 and 2011, African-American as well as Medicare and Medicaid patients had significantly higher rates of complications, length of stay, and 30-day mortality. They also found that the African-Americans, and in this study, Hispanics, were less likely to undergo surgery at all. But there was no difference in the rate of the surgical methods used in that study. As far as emergency colorectal cancer surgery, again, the results are going to be worse for that. And this study showed that the percentage of patients requiring emergent surgery was higher in the African-American group versus the other groups. Medicare insured groups were higher versus patients with other insurance types. The percent with metastatic disease was also higher in those requiring emergency surgery, which is not surprising, and the comorbidity rate was also higher. And as far as the mortality, of course, for the emergency cases, it was in fact higher. What about screening? In New York City, there's been a big push for more colorectal screening across the board in HHC hospitals and others. And this is a study that looked at up until 2016. And clearly the rate of screening changed dramatically. And then the good news is at the end of the study, the rate of screening in the different race groups and ethnic groups was similar, which is as it should be. And also during this period, as we've already heard, that the incidence of colorectal cancer has dropped. However, despite that, there's been still a higher rate of incidence of colorectal cancer in the African-American groups versus the Caucasians. Interesting, if you look at a VA population where the cost of the exam is no longer an issue, we find the overall screening rate actually is quite high, and there were no significant differences in this study in regards to whites, African Americans, and Hispanics. However, American Indians and Alaska Natives had a significantly lower rate, and also patients who were in the lowest socioeconomic quintile, and also those that had substance abuse or mental health issues as well, had a lower screening rates. And this is different than what's seen in the population at large. Finally, income mobility, as you look at the impact of income in the higher income groups, the results tend to be more similar, and in the lower groups, the results are worse. Again, the African American, we have the most data for the African American subgroups, and clearly that this is an important factor as well. To summarize, clearly there's differences between races have been noted for the parameters that I've listed there, and it goes beyond it's the stage of presentation, but also the overall general health and the care of those comorbidities is different. Insurance status is different, and it impacts the number of patients that get to surgery and the type of surgery that we do, and this impacts in turn the outcome. Clearly, the worst outcomes are in those groups as noted. And the idea of a minority serving hospital is also, it was new to me, but it was something that's important for us to realize that we need to try to kind of standardize the care that's being given in all hospitals. And I think we're actually making strides that way, but is more to go. And obviously the screening programs are critical. The tumor boards are of critical importance, and I think that's here to stay, and I think that will help. And we also need to standardize our surgical treatments, it's still in flux. There's lots of different choices, but as long as they're being scrutinized, the results will be able to come up with recommendations for that. And again, finally, to get back to the genetic piece of this, we need to figure out if we're dealing with apples and apples, or if it's apples and oranges, or proportions of patients that may have a different type of cancer that may require a different type of treatment. Thank you very much for the chance to speak to the group. Thank you.
Thank you, Dr. Whalen. I would now like to invite all of our panelists to turn their cameras back on for the discussion portion of this session. Thank you all for your interesting talks. I do want to highlight, I have one question for all of our panelists that we will be able to take currently. And then there's also one question in the Q&A box that I invite our panelists to also be able to comment on as appropriate. The question that I have for you all is, as we're well aware, the COVID-19 pandemic has disproportionately burdened many of the populations that were the focus of these talks, including individuals from racial and ethnic minoritized backgrounds, individuals who are diagnosed with colorectal cancer survivors, and also those who are living with multiple chronic conditions. And so just wanted to hear your thoughts with respect to either research or clinical practice as to how we can move forward to begin to reduce some of these inequities that have been exacerbated through this pandemic.
In addition to being a lab scientist, focusing on mechanisms of cancer, I also am a practicing gastroenterologist. So my perspective on this is, as someone who performs screening colonoscopies on a regular basis to reduce cancer incidence and mortality. And when the pandemic hit, we, for I think many good reasons, had to really shut down our screening colonoscopy programs. Evidence published recently has suggested that the COVID-related shutdown in colonoscopy guided screening programs has resulted in an unfortunate increase in colorectal cancer incidence. So that's very unfortunate. Furthermore, that this impact may be disproportionately impacting lower socioeconomic groups and minorities that already at baseline have low access to care. So I think we need to do an even better job now of reaching out to those who missed their screening colonoscopies in the last 2 years, getting them scheduled, and having a more proactive approach, potentially a population-based approach to increasing access to care rather than just passively waiting for patients to show up, since that often ends up being those who have already had a baseline colonoscopy and looking for a follow-up, or have insurance, or have the connections and the wherewithal to know that they need to be screened.
It's such a great question. So I was just jotting down a few potential opportunities. So we have at Northwell, we have a value-based gaps in care program where we really look into the insurance companies to find patients that may not have been screened on time. So we have a pretty intricate system of sending letters out to those patients. So I think my suggestion would be finding a way, however a health system can do it, is trying to partner with other entities that could help identify patients that are missing that screening. And then also an insurance would be a great place to start. But then also, I just think that there needs to be sort of a two-pronged educational approach with providers and patients, and try and get as much information out to both of those parties, however that would be best disseminated, to just increase knowledge of the importance of screening, because people aren't running out to get a colonoscopy anyway. And with COVID, like we know, that just put it off even further. But if we can try and show people that this is a preventable disease, and it doesn't have to be this way, it doesn't need to be the second leading cause of cancer among men and women combined. So I think the educational approach and then some kind of tactical approach with partnering would be a potential area of opportunity.
Great points on the multi-pronged approach. Dr. Siebel?
So I echo what my colleagues had said, especially in terms of screening and reaching out. So as a medical oncologist practicing through the pandemic, yes, many, if not most of my patients did delay their screening and are still making up for it today. Obviously educating them on a regular basis as to the importance of screening is what we're doing ongoing. An interesting thing that we employed at Northwell in terms of medical oncology and treating our patients through the pandemic for safety reasons is that we knew the patients needed to get treated, and that was the most important thing that we had to do, was to get them in and get them in safely. So as a group, through multidisciplinary meetings, we all came to consensus on how can we decrease the frequency of the patients coming into the office by being able to, maybe convert some of their IV medications to oral medications, And we were really able to cut down on the in-office visits that way and not jeopardize their care in any way. One area I think is important to know is that the oral drugs do tend to have copays. And I did see some reflection in terms of disparities among patients who could afford the copays and who could not. And that is a very important area that I think needs to be addressed should there ever be an uprise or a pandemic again, where we would need to switch to more oral drugs. So we did learn that through this, but I'm happy to report that at least in my practice, I was able to get all the patients in to be treated appropriately. And I don't feel that people really lost out on treatment. Screening, yes, but treatment, no.
Thank you. Dr. Whalen?
I think there's already been covered pretty well, but I would point out one thing is that not only do we need to lower the screening age, which went to 45, and I think we could even justify going even younger than that, to be honest. Especially for many people, and the idea of knowing your family's history as opposed to just saying they had a colonoscopy and they didn't have a cancer, is not enough information. But also the idea of patients that come in who are young that are symptomatic. I mean, it's still not accepted that if you have somebody who's 23 who has rectal bleeding, they need a colonoscopy. I mean, this is, and at the GI world, Dr. Roper knows this, and we scope everybody now. 30 years ago, you couldn't do it, but we have to do this. And so the idea of educating both the doctors about this, as well as educating the patients as well. But so that two-pronged piece is there. And also trying to always push back on the screening age, because with the only area where we're seeing increase is in the under 50 group, and we're seeing a frightening number of patients in their 20s with this. And a month does not go by that we don't see a patient who's under 40 with cancer, or in their early 40s, and as we've heard, they're all advanced. So I think we need to educate the docs. And we need to not feel bad about doing and the idea of flexible sigmoidoscopy, there's almost no indication for it anymore. I think we need to do, if you're going to do an exam, you do the colonoscopy.
Thank you all for your presentations and for your remarks. Just to highlight, there are 2 open questions in the chat. One around screening, exactly what we were just discussing around screening in earlier populations, and also around social determinants with respect to access to healthy foods and physical activity, and how that could potentially impact associations between obesity and colorectal cancer. So we are at time. So thank you all for your presentations. If you have a moment, please do place your feedback into the chat.
So we will take a short break.
So it's great to be here. Great to be here, and I am very honored to be the moderator of this panel session. One, because I love pancreatic cancer research and love talking about how we can better treat it and detect it, and 2, because of the participants we have in this session. I have a special relationship with both of them. The first one, very special relationship, because when I started coming to this conference years ago, I met him when he was a graduate student, and now he is Dr. Oni. So I'm totally honored to be introducing him. So without any further ado, we have Dr. Oni today. We used to call him Toby, but I'll call him Dr. Oni today. He has a BS in biology from SUNY Plattsburgh. He has a PhD in cell molecular biology from Stony Brook University. He did graduate research in my colleague Dave Tubison's lab, who I'm happy to see here as well today. And now he is a postdoc at the Whitehead Institute as a Whitehead Fellow, which is based at MIT. He started that in 2021. So totally honored to be introducing my friend and colleague who I've seen grown up over the years, look all grown up now. And just can't wait to hear his presentation. And his presentation today is interrogating the tumor cell surfaceome in pancreatic cancer. So Dr. Oni, welcome. And I'm very proud of you.
Thank you very much. Can everyone hear me? I was actually at the first conference for cancer health disparities at Downstate, and I was there as a grad student with Dave. But now, last year I opened my lab at Whitehead Institute at MIT, and it's been such a rewarding experience, because this is this is really how and where I grew up. So today I want to tell you about some of the work I did before I actually opened my lab, and this work actually serves as the critical basis of what we do now in my lab. So, you know, we know that in pancreas cancer, early detection is crucial. You know, obviously I didn't want to push to the choir and talk about how lethal the cancer is. It's obviously lethal. But in terms of the you know, things we can do to really change the course of this disease, it's really clear that if you look at, you know, the cases that patients present with, actually majority of patients present with distant disease, where the disease has metastasized to other organs, and only 11% or so present with localized disease that is amenable to surgical procedures. And if you look at the survival rate, it's the complete inverse of that caseload. So in fact, you know, those 11% tend to live longer, and their 5-year survival rate is about 40% or so. But majority of the patients actually, you know, have a very low survival rate. And if we can just shift that, you know, population, the number of cases, just by that alone, we can really dramatically improve, you know, the prognosis of pancreas cancer patients. And so what are the problems in terms of being able to detect this earlier and shift that number of cases? We know that there are no accurate early detection markers. And actually, you know, CA19-9, which is used as a tumor marker to follow the disease burden, is actually, you know, one of the factors that could contribute to health disparities, given that about 10% of Caucasians don't make it, but about 25% of African Americans and about 20% of Asians cannot make it, regardless of if they have cancer or not. And for these patients, you know, following disease burden can be, you know, done by other means, but at least this CA19-9 method is not even available for that case. The second aspect also is that even when we think about imaging methods that are typically used to diagnose pancreas cancer, they're not accurately sensitive, particularly to detect, you know, occult metastasis. And this can really lead to staging problems and this understaging where you stage patients in the wrong way. And to solve these problems, we basically need ways to identify the tumor cells wherever they are and identify them early. And that's the critical aspect. And my perspective of this when I was developing this project is just the fundamental idea that the genetic aberration in tumor cells lead to dysregulation of several processes, expression, you know, splicing and post-translational modifications. And you can imagine that these modifications can really differentiate tumor cells from normal. And if we can use antibodies, if we can generate antibodies that can selectively bind to those modifications or to those changes that are tumor selective, we can really potentially detect cancer wherever it is, you know, if it's in the blood, if it's in other tissues or in the primary tumor. And so the way I went about doing this is very straightforward. We use the immunization process that is used in this hybridoma method. So basically, we inject tumor antigens, particularly cell surface antigens, into rats. In this case, we isolate the plasma cells that actually make antibodies to those antigens, and then we fuse them with myeloma cells and screen them for the clones, and then expand the clones to test them for the ability to selectively detect pancreas cancer. And so this has been used before, and typically, you know, people use, back in the days, people would use homogenized tumor tissue. But the problem with pancreas cancer, and something that Dave talks about a lot, is this oatmeal cookie problem, where the cancer cells actually represent a minority of the population in the tumor. And so injecting homogenized tumor tissue is really, you know, not very effective. Also, cell lines are used in this method, but they don't really recapitulate the biology. and heterogeneity of pancreas cancer. And so we developed the Organoid System a couple of years ago, and this has really changed the field in multiple ways because it allows us to do, grow patient tumors ex vivo, and it allows us to retain the heterogeneity, both intra and intertumoral heterogeneity in these patients. And the goal here was to combine multiple of these patients and find antibodies that bind to shared tumor-specific antigens. And that's basically the idea of this project. So what we basically wanted to do was to produce the antibody, validate and characterize them, and then test them in several applications to see whether they can actually be translated to the clinic. And this is exactly the process of producing the antibodies. One thing I would just want to point out here is the use of the membrane fraction to really target the surface, the accessible proteome of pancreas cancer. And so we had this assay just to basically screen cells after developing these antibodies, and we find some antibodies that bind to tumor cells. And those are the clones here in red. And for this assay, about 18% of the clone were positive for binding. And so the next question was, well, I mean, are they really binding to this accessible proteome, to this surfaceome of pancreas cancer cells? And so we did a screen using flow cytometry on intact cells. And in fact, you see several of these antibodies that bind to the surface of pancreas cancer cells, where you don't need to poke a hole in the cell to really get the antibodies to bind. And so in summary of the first part, we really were able to develop antibodies that bind to the cell surface of pancreas cancer cells. And from now on, I'll call this antibodies TOBI-bodies, and it doesn't stand for my name, obviously. Instead, it stands for tumor organoid binding antibodies. And so with these TOBI-bodies, the obvious question was, well, do they really differentiate between tumor and normal? And the best way to do this is to just basically take tumor sections from patients and actually ask from the same patient, if you compare the tumor and the adjacent normal, what does it look like? Does it really selectively differentiate between this? And so obviously, like any self-respecting scientist, you would have a control. IgG control does not show any binding. So the blue you see is just the cells. Typically you will see binding, which is brown, but there's nothing here. But when you use these TOBI-bodies, it really selectively binds to the pancreas cancer cells. And you can directly see this by comparing it to the adjacent normal. So we had several of these TOBI-bodies, and we had a total of 16 of them. And so the next question was like, well, what are they binding to? And the key point here is to note that these antibodies are binding to epitope. They're not, they bind to the antigen, but they bind to a very specific part of the antigen. And it's essentially possible that some of these antibodies might be binding to the same antigen, but different epitopes. And so we did IP mass spec to really identify some of these antibodies in terms of what they bind to. And we found that several of these antibodies bind to CEACAM6. Now, CEACAM6 is an antigen that is a protein that is known to be overexpressed in pancreas cancer. And so this was quite interesting to us because actually several of these antibodies bound to CEACAM6. So I actually just did an ELISA to test, well, do they bind to CEACAM6 and do they also bind to CEACAM5, which is a very related protein. And it turns out that a lot of these antibodies either bind exclusively to CEACAM6 or they share an epitope between CEACAM6 and CEACAM5. And this clearly means that some of these antibodies are clearly binding different epitopes on the same antigen. And that's what I've illustrated here. And so the next question was just to ask whether these antibodies were really binding to this epitope. Like if you knock out this CEACAM6, do they lose binding? And that's exactly what we find. This is a control CEACAM6 antibody. And when you look at these TOBI bodies, you see that they completely lose binding when we knock out CEACAM6. And so in summary of this, we identify several TOBI bodies that basically bind to similar antigens, such as ITGA2, MUC1, CEACAM6, and CEACAM5. And so the next question was, well, they differentiate between tumor and normal cells in the pancreas. What about the whole body? And this is entirely possible because there are certain things that are expressed in the pancreas that are not expressed in the pancreas, but then become expressed during tumorigenesis, but then they're expressed normally in other parts of the body. And this is just an example of such a pattern of expression. And so it's also possible that these proteins are expressed, but then they have a post-translational modification that is specific to tumor cells. And in that case, you would not find them in other parts of the body. And so to really test these antibodies, we tested normal human tissues and compared them to PDAC tissues and did immunohistochemistry. And very interestingly, we saw that if you use a commercially available CEACAM6 antibody, it binds to the pancreas, to the pancreas cancer, but not to the pancreas. And so the same also goes for these TOBI bodies. But what really blew my mind was the fact that some of these antibodies were binding to CEACAM6 in the esophagus, for example. But then we had this TOBI bodies that bind to the same antigen, but likely bind to different epitopes because you can't find that epitope in other normal tissues in the body. So this suggested that they were tumor specific. But I mean, what about inflammation? So we tested this in chronic pancreatitis and saw that this TOBI bodies did not bind to pancreatitis or normal pancreas, but bound to the majority of PDAC patient tissues, which means that this is a shared antigen across PDAC patients. And so the summary of this is that we were able to develop TOBI bodies that has selective binding in the pancreas to pancreas cancer. But two of these TOBI bodies were really specific to pancreas cancer, but not to other normal tissues or to pancreatitis. And so we think these TOBI bodies are really promising to be used to detect this cancer in patients potentially. And so we can use these TOBI bodies for that. We can use it to detect for imaging, Immunopath imaging. But also they could be useful to deliver drugs to pancreas cancer, using antibody drug conjugates. And we can also, start to imagine, well, what are these things binding to and what do they do functionally? And actually this is subject of intense investigation in my new lab. But just to give you a quick snapshot before I round up, we decided to go with the Immunopath approach, where we just radio-labeled TOBI-89 and use this in a transplantation model where we inject human tumors organoids into the pancreas. So we inject into the parenchyma of the pancreas and you get a big tumor. And this tumor, you can actually see it by small animal imaging. So it's not very surprising. We should see it by Immunopath imaging, and that's exactly what we see. So we see this really nicely by Immunopath imaging. But again, this is not surprising. You could actually practically feel the tumor, using your hands. What about really tiny tumors? Can this potentially identify incipient PDAC? And so Koji Miyabayashi in our lab at the time developed this really nice model where he's able to inject pancreas cancer organoids into the duct of the pancreas, and it forms this really nice tiny tumors, multiple tumors along the length of the pancreatic duct. And you cannot see these tumors by ultrasound imaging, but we could really nicely see it by Immunopath imaging. So this suggested to us that these antibodies could be really useful to delineate the small tumors that we potentially removed before it causes trouble and spreads to other parts of the body. And so this is the bulk of the work. We're doing a lot of work with premalignant lesions at the moment. And our work suggests that these antibodies are really binding to frank PDAC rather than just like, low-grade pannins. And we're humanizing these antibodies because they're rat antibodies. And finally, we're curious about how we can use these antibodies to deliver therapeutic payload to the tumor and really concentrate poison to these tumor cells. So, the last part we're doing also is to really identify exactly where these antibodies are binding to, identify what they're binding to, and potentially understand the biology of this particular marks. And so I'm going to end there. And I just want to thank Dave, who's been just a remarkable human being in my life, and it's just opened a lot of doors for me. I will not be where I am today without Dave, so thank you so much. Obviously, I want to thank a lot of people in the Tumor Lab that really made this work happen. And also our clinical collaborators, both Johns Hopkins and UPMC. And particularly, I would like to also thank Jason Lewis, Jaron Goose, and the Lions Lab that really were instrumental in the imaging aspect of things. On that note, I'm going to stop here, and I guess we'll ask questions at the end.
Thank you, Dr. Oni. Very interesting presentation as always. Definitely look forward to the question answer period during the panel session. So again, for those of you that have questions, please feel free to put them in the chat or save them for the panel session that will occur after our next speaker. So again, thanks again, Dr. Oni. I have the pleasure of introducing you to someone who basically started my career in pancreatic cancer. Just as Dr. Oni talked about Dave Tuvison, I have a similar person in my life that has done that. That's Dr. Channing Durr, who's our next speaker. He was my postdoc mentor and started me down this path of pancreatic cancer research. So I'm totally grateful for that. Just a quick introduction. He has a BS in biology from UCLA, a PhD in microbiology from UC Irvine. He did a postdoctoral fellowship in pathology at Harvard Medical School and Dana-Farber Cancer Institute. He's currently a Sarah Graham Keenan Distinguished Professor of Pharmacology at the Lineberger Comprehensive Cancer Center at UNC Chapel Hill. He is one of the forefathers of RAS mutations, of the importance of RAS in human cancers. He's one of the fathers that helped to make that known to the scientific community, and has been involved in that effort ever since, and has made some serious contributions in that area. He has various funding from NCI, DOD, Les Garden Foundation, PanCan, ACR, and others. Has over 420 publications and holds over 10 patents, roughly 10 patents. Has mentored over 50 postdocs. I'm one of them. And is involved in many aspects of cancer research, and as well as pancreatic cancer, and has received numerous awards, including a mentorship award for lifetime achievement. So again, it's an honor to have the honor to welcome and introduce my colleague, my mentor, and my friend, Dr. Channing Durr. It's all yours.
Well, thank you, Tony, for that very nice introduction, and also thank you to the organizers of the meeting for the opportunity to participate in the discussion of obviously important issues regarding cancer disparities, in particular with GI cancers. So as Tony indicated, my research is involved in pancreatic cancer and specifically dealing with the RAS oncogene. And so today what I'd like to do is just give you a brief update in terms of where we now stand with regard to these efforts. So first of all, my disclosures with regard to my financial relationships with various companies. And this indicates actually the robustness of the activities that are ongoing with regard to targeting RAS, because essentially all these activities involve companies that are focused on developing anti-RAS therapies. So Pancreatic cancer, many of you already are very familiar with the fact that this is a very deadly disease. It's the third leading cause of cancer deaths in the US and projected to become the second leading cause by 2030. Has a dismal 5-year survival rate of 11%. And important for the theme of this meeting is that disparities by race and socioeconomic status exist in the diagnosis and treatment of pancreatic cancer. And these are largely driven by race and socioeconomic status. And specifically for the focus of my presentation, what is relevant is that despite the fact that we now have a very well-defined genetic landscape of pancreatic cancer, but despite that knowledge, we've not been able to harness this to develop effective targeted therapies for pancreatic cancer. And unfortunately, our current standards of care remain largely ineffective conventional cytotoxic drugs. So the question is KRAS our best hope for trying to make significant inroads into improved treatments for pancreatic cancer? So I take you back in time when the first associations between RAS and pancreatic cancer were first described. And this goes back to a study by Manuel Perucho in 1988. This study, together with additional studies, then led to Ralph Rubin proposing a genetic progression of pancreatic cancer, as shown at the bottom here, where KRAS is one of the earliest events associated with this progression. I take you to 2008, when Ken Kinsler, Bert Vogelstein, and colleagues determined the first genome-wide profiling of pancreatic cancer, where they identified 12 core signaling pathways that define pancreatic cancer. They also determined that pancreatic cancer approximately had about 60 genetic alterations per cancer. These studies were followed by many other genetic sequencing studies. And today we have a very detailed profile of pancreatic cancer. It's in its simplest form. What we see here is that there are 4 major genetic alterations, beginning with KRAS activation, followed by the inactivation of 3 key tumor suppressor genes. And so this perhaps gives you a better appreciation for the genetic landscape of pancreatic cancer, which is that on one hand, it is a genetically diverse and heterogeneous disease. But additionally, you can see very clearly here in this word cloud that KRAS is the dominant genetic alteration in pancreatic cancer. So we now know that pancreatic cancer is perhaps the champion of all cancers that have RAS mutations. RAS mutations are prevalent throughout cancer. Approximately 20% of all cancers have RAS mutations. At the very top of this list is pancreatic cancer. Essentially, every pancreatic cancer has a KRAS mutation. So this, of course, led to the determination that one of the 4 major initiatives for the pancreatic cancer research community was the development of therapies targeting RAS. And so we now believe that KRAS is an essential driver of pancreatic cancer growth. And a lot of effort has been initiated to try to develop anti-RAS therapies. And considerable effort has been made in academia as well as in industry. But this clearly has been a very difficult challenge. It has not been easy. And so that is why I refer to targeting RAS as the long and winding road. And I cite Paul McCartney in his song, The Long and Winding Road. He describes the basis for this song, which is all about the unattainable, the door you never quite reach, the road that you never get to the end of. In some ways, in the study of RAS, it has seemed as if it's something that no matter how hard we tried, we seem not to be able to get to the end of this road. However, and part of the reason is that it has been a complex initiative. And clearly we have made mistakes along the way. We've had bad misconceptions and we've had embarrassing missteps. So for nearly 4 decades, RAS was considered undruggable, and we wondered if RAS will ever be broken. Well, in 39 years of research, we have finally reached that point. And I've been involved in essentially every year of that initiative. I was involved in the early discovery of RAS in human cancers. And now I take you to 2021, where the first approval of a RAS inhibitor was developed for lung cancer. And so in May 28, 2021, sotorasib received accelerated approval for the treatment of KRAS mutant cancers. So this approval was not for all KRAS mutations, but one specific mutation, KRAS G12C, which is a heavily smoking-associated mutation. And current indications are that about 35% of lung cancer patients are responsive to this treatment. Now, we also know that just because you have a KRAS G12C mutation in another cancer type, the response may not be the same. And in fact, the results of colorectal cancers have been certainly a bit more disappointing, about a 4-fold less response. The overall response rate is about 10%, and the responses are less durable and those seen with lung cancer. What's the situation with pancreatic cancer? Well, first of all, this mutation is relatively rare in pancreatic cancer and comprises less than 2% of all KRAS mutations in pancreatic cancer. But despite the low frequency of this mutation in pancreatic cancer, the results from early clinical trials are quite promising in that about 50% of pancreatic cancers with this mutation seem to be responding. So this is quite exciting, and this bodes well for other KRAS targeted therapies for pancreatic cancer. So, and there's hope along the way. I told you that the first approved inhibitor is for only one RAS mutation. If you look at cancer, there's over 150 other missense mutations identified in KRAS. So we need to find other inhibitors for other mutations. And these activities, as outlined in this slide here, are very robust, and this is just the tip of the iceberg. So at this point, you might say, is our effort to target RAS in pancreatic cancer reaching an end? Have we finally climbed the Mount Everest of pancreatic cancer research? Unfortunately, as is typical for essentially all targeted therapies, resistance arises. So while patients are responding fabulously to this treatment, the responses are short-term, about 6 months for lung cancer patients. Essentially, all patients relapse and resistance arises. So a number of studies have now been published to begin to identify the mechanisms of resistance with the goal of trying to then develop combination strategies to block the resistance mechanisms to achieve a longer, more durable response. And at the panel I've shown you on the right, this indicates some of the mutations that have now been identified in relapsed patients. And not surprisingly, the vast majority of genetic alterations that have been identified involve reactivation of RAS and the MAP kinase pathway. So the MAP kinase pathway is the key downstream effector of RAS-driven cancer. So just to demonstrate the importance of the MAP kinase pathway in RAS-driven pancreatic cancer, in this experiment here, a postdoc in my lab, Jenny Klomp, she put in an activated MEK1 component into pancreatic cancer cells that had a KRAS G12C mutation. And what you can see here is that the cancer is now largely non-responsive to the G12C inhibitor, but still responsive to an ERK inhibitor. So this is still a ERK-dependent pancreatic cancer, but now in a hyperactivated RAS situation, ERK-MEK situation, it is now bulletproof from a RAS inhibitor. Further demonstrating this, there is now development of inhibitors for other mutations, and in particular, a G12D specific inhibitor was recently described. And this is great for pancreatic cancer because G12D mutations comprise about 45% of all KRAS mutations in pancreatic cancer. And shown at the bottom, once again, if you put an activated MEK1 allele into pancreatic cancer cells with a G12D mutation, this cancer cell becomes largely unresponsive to a RAS-driven cancer treatment. So at this point, I think all these indicate that ERK will be the Achilles heel of essentially all anti-RAS therapies. So what I'd like to do to finish off my presentation is just to describe some of our efforts to try to develop effective therapies to block ERK, to facilitate the effectiveness of KRAS mutant treatments. And so we've applied a number of omics approaches, some of which are outlined here. And I'll just briefly highlight some of the results that we've gotten from some of these studies. So one of the first things we did was to try to define the KRAS transcriptome, the genes that are deregulated by KRAS mutation activation. Of course, many of you are familiar that there is already a hallmark KRAS signature, but we questioned whether this was accurate for pancreatic cancer. So we decided to take a different strategy to identify KRAS-dependent gene transcription. And basically that involved using KRAS mutant pancreatic cancer cells, acute silencing with siRNA, followed by RNA-seq. From this analysis, we identified a complex transcriptome for KRAS-driven cancers. And what you can see on the left here, on the right, are genes that are identified to be upregulated, as well as genes that are downregulated. So the question is, how does this compare to the hallmark KRAS mutant signature? Well, I won't describe that, but the punchline from that is that we have found that our signature is surprisingly very distinct from the conventional KRAS signature. And we believe that a lot of the differences in our KRAS signature are due to pancreas-specific gene expression. But what I'd like to emphasize is that not only did we determine the KRAS transcriptional signature, but we also did the same for an ERK-dependent signature. And this heat map shows the comparison of genes that are upregulated and genes that are downregulated upon either KRAS ablation on the right, followed by ERK inhibition on the left. And what you can see is there's a significant similarity between the genes that are deregulated in response to either ERK inhibition or RAS inhibition. Showing you this in closer detail, what I've shown here is the top 100 deregulated genes, either by ERK inhibition or KRAS inhibition, and compared them. And what becomes apparent is that about 90% of the KRAS transcriptome can be blamed on ERK. So from this, we conclude that ERK does the heavy lifting for RAS. So just further evidence for the importance of ERK. Here is a similar experiment where an activated ERK allele was added to a G12C mutant pancreatic cancer cell line. And once again, you can see that basically this pancreatic cancer cell line is now bulletproof to a KRAS inhibitor. So this demonstrates very strikingly the importance of ERK reactivation in driving resistance to RAS inhibitors. So of course, there are many inhibitors that have now been developed to target this pathway. What has gone on? Well, unfortunately, to date, no inhibitors of this pathway have been approved for KRAS mutant cancers. And there's several problems that we have facing. First of all, targeting ERK has shown limitations by normal cell toxicity, as well as cancer cell resistance. So how do we overcome these limitations of targeting the RAS-MAP kinase pathway? The first strategy are combinations, and the second strategy is dissection of the ERKome. So let me just briefly summarize combination studies. We've taken a variety of approaches, including chemical library screens, such as that shown here. I won't go through these in detail, except just to summarize the fact that through a number of studies, we have now identified a number of ERK inhibitor combinations that enhance the ability of an ERK inhibitor to be much more effective. And I'll just highlight one of them, a study that we published in 2019, targeting autophagy. And so this is a study that was led by Kirsten Bryant, then postdoc in my lab. And she showed that combining ERK inhibition together with autophagy inhibition synergistically suppress pancreatic cancer growth. And so basically the mechanism that was based on this is that when she found that when you treat pancreatic cancer cells with an ERK inhibitor, you block two key metabolic processes, glycolysis and mitochondrial function. The cancer cell attempts to overcome this by increasing autophagy. And so we projected that due to increased dependency on autophagy, pancreatic cancer cells would now be more vulnerable to autophagy inhibition. And certainly this has been the case. And so our study, together with several others, reached this conclusion that concurrent inhibition of the MAP kinase pathway on autophagy will be an effective treatment for RAS mutant cancers. And so certainly in the study by Martin McMahon and Colin Kinsey and colleagues, they identified a patient that responded dramatically to this combination. And the net result of all this is that a number of studies, clinical trials have now been initiated to evaluate the combination of inhibition of the ERK pathway together with autophagy. And finally, let me just briefly discuss targeting components downstream of ERK. And so we have now taken an approach to try to dissect what ERK does. The first approach we've taken is to determine the ERK phosphoproteome, since ERK is a protein kinase. This is what we did. We took KRAS mutant pancreatic cancer cells. We treated them with an ERK inhibitor. We did mass spec proteomic analysis to identify ERK-dependent phosphorylation events. We then compared it to what is known in the literature, and a lot has already been done. Over 14 studies have been done to identify ERK substrates. Yet despite the fact that this has been done extensively, our analysis has identified perhaps about 50% more ERK-dependent phosphorylation events than was previously described by essentially the entire history of proteomic analysis. And so this just shows you in dramatic fashion. The gray circle indicates what we identified, and the other circles indicate the phosphosites that have been identified by and related to ERK by other studies. So we think that we have now generated perhaps the most comprehensive profiling of the ERK-dependent phosphoproteome in pancreatic cancer. And so we've begun to look to see whether any of these are potential therapeutic targets. This is just a comparison of our ERK substrates together with data from the DepMap from the Broad Institute, Project Achilles. And we had shown here is that a subset of the proteins that we identified are indeed essential for pancreatic cancer growth. And this just shows that the genes that have been identified are those that are largely involved in nuclear functions. And so currently what we have done is we've made a CRISPR library that corresponds to the ERK substrates that we've identified. And we're doing a CRISPR screen in the presence of sublethal concentrations of an ERK inhibitor to identify those that are important for driving ERK-dependent pancreatic cancer growth. So let me just end by the basic punchline from my presentation, which is that combination therapies for targeting KRAS and the ERK MAP kinase signaling network will provide effective treatment for a majority of pancreatic cancers, given the high prevalence of RAS mutations in pancreatic cancer. So I'll end there, and I'll just acknowledge people in my lab who've been involved in these studies. Certainly, we've had many great collaborators. I have a lab of incredibly talented and dedicated people. And this is also the funding that we've received for our studies. So I'll stop there, and I'll take any questions, I guess, in the upcoming panel discussion.
Thank you, Dr. Derrick, for your very informative presentation on the future of RAS and ERK as well. So thank you so much. Thank you so much. I appreciate it. So we'll now open up for questions for both of our panelists. So again, if you have any questions, please raise your hand or put it in the chat. I see some questions already. So I'll go ahead and ask one of them for Dr. Oni. So Dr. Oni, so you received a question and it says, has any work been done to assess if the TOBE bodies can be used to screen for circulating tumor cells in blood samples?
Oh, that's a terrific question. We haven't worked on this, but you know, if I were to guess, I would imagine they would be useful in that context, and it's something that I think we should really do for sure. Okay,
and one more question for you, Dr. Oni. It says, I want to know your input on the importance of the role of tumor biomarkers in the early detection of pancreatic cancers. For example, like PCNs, for example, pancreatic cystic neoplasia, and other types of pancreatic types of cancers.
Yeah, so using tumor biomarkers, and particularly, being able to detect those biomarkers are really important. And I think, one of the things that actually spurred this project was that desire to find, ways to actually easily, non-invasively, find early cancer. What we're doing at the moment is actually to look at a lot of, for example, IPMN, which is a cystic lesion, and there are other cystic lesions too. And, one of the key things to be able to do in that context is to be able to tell, when you find these cystic lesions, because they're large and they're easily diagnosed, but when you find these lesions, which ones are actionable? That's a critical question. And one of the work we're doing now is actually to just look at whether this Toby bodies bind to IPMN at all, or so other cystic lesions. But something to do in the future would be actually to see samples from who progressed and who didn't progress, and to see whether we have certain staining at a certain point that suggests that certain patients will progress and become and will progress into frank PDAC. So I think that's very, very critical, because whether we do something about certain lesions will be important to be able to differentiate which ones actually are very benign and wouldn't do anything, and which ones actually go on to become a bad cancer.
Thank you, Dr. Oni. Dr. Durr, I have a question for you, a few questions for you. So why do you think the ERK pathway, and you know better than all of us, the many different downstream pathways of RAS, why do you think the RAF/MEK/ERK pathway seems to be a very predominant pathway in pancreatic cancer, and compared to the many other pathways that you and others have discovered? And then do you think that this ERK pathway is also playing a strong role in other RAS mutated cancers like lung cancer and colon cancer?
Yes, so that's an excellent question. As you indicated, RAS activates not one, not two, but there's at least a dozen downstream RAS effector pathways. So why is pancreatic cancer so dependent and utilizing primarily one of those pathways? Not a clear answer to that question, but it certainly appears to be the case, and it doesn't seem to be necessarily the case in other KRAS-driven cancers. For example, perhaps the second most predominant RAS effector pathway that's well established in cancer is the PI3 kinase AKT pathway. That one seems to play a fairly minor role in pancreatic cancer. In contrast, in colorectal cancer, it seems to play a more significant role. So certainly, we do now see that KRAS in pancreatic cancer is utilizing driver signaling pathways in a different way than other cancers. And this goes to even other extremes. For example, HRAS mutations in head and neck actually are less dependent on the MAP kinase pathway. And so we see even other differences when we go to other RAS genes and other cancers.
Interesting. You have a question, Dr. Durr. Does senescence play a role in resistance to KRAS G12C inhibitors?
I'm sorry, what was that again?
I'm sorry. Does senescence play a role in resistance to KRAS G12C inhibitors?
Yes, that's an excellent question. And that's one where what we sometimes will see is that when you treat cells with a certain therapy, there's not death, but there is the cancer cells are somewhat dormant, and senescence is one thing that does occur. And that consequently can lead to a situation where the tumor cells will persist and may come back again when something else occurs in terms of other genetic alterations. So certainly senescence is one thing that the MAP kinase pathway is well established for in driving in pancreatic cancer.
Okay, and ERK is such a non-specific phosphorylating pathway. So will it be very difficult to target the specific pathway? How to determine the specificity?
Yes, that's always an issue that we face. How selective is a target for the driver? And that's in part why we limited our profiling of phosphoprotein proteins to those that were ERK dependent. And that way, we hope that we can identify a target that is much more restricted to ERK signaling, and as a consequence, much more focused on RAS-dependent cancer growth. But that is always an issue that we face. How selective is our target for the drivers that we want to block?
Dr. Oni, do you think your approach may also identify therapeutic targets?
Absolutely. We think because this, antigens are on the cell surface, they're accessible. And that's the beauty of this, because we can target them. So even if they're not, dependencies by themselves, they can still represent a way to target the tumor cells by directing poisons, which is chemotherapy, to the tumor cells in high concentration. Now, one of the interesting things is, well, when we identify these targets, do they actually have a role to play for the cancer, and are they helping the cancer cell? And so by blocking their function, can we abrogate the growth of these cancer cells? That is an interesting question that we're working on. We don't know the answer yet, but we'll find out. So particularly one thing I'm currently doing in my new lab is actually to look at how some of the modifications on these proteins can really have an impact on the immune system. And it's very clear that there's a correlation between the abundance of these proteins and the ability of immune cells to not be able to kill cancer cells. So that's one of the functions that we think if we can perturb that, then we'll be able to really, drive therapy and actually have better options for the patients.
Okay. And I want to ask you both a question. As you both probably know, pancreatic cancer is a health disparity cancer. It's been shown to be high, unfortunately, in African Americans, for example. I would love to hear your thoughts about, do you think that's biological, socioeconomics, both, and how you think we can tackle that?
Maybe Shannon want to take a big bite of that.
give it to the senior professor to.
Okay. Well, I mean, certainly at this point, is there a biological genetic basis for this, or is it largely driven by socioeconomic issues? It's clear that the latter has a major role in this. African Americans are diagnosed later in the disease than others. African Americans, as well as Hispanics, are less likely to be undergo surgical resection for the disease. And so there clearly are socioeconomic issues. In terms of whether there are genetic biochemical basis for it, the work that you and others are doing, in which we now have a greater access to model systems that can reflect diversity, I think will be important to address that question. So at the end of the day, I think that there will be, but until we have the resources and ability to do it, we're not going to be able to effectively answer that question.
Yeah, and just to add to that, obviously, like a very wise man, he really answered, the majority of the question, and I think that's exactly what I think. But I wanted to add to that and say that the biological basis is still, we've not established whether there's a biological basis yet, but it's very clear there's socioeconomic basis for this. I mean, that is very clear. But in terms of biological basis, what would really help us to answer those questions is some of these model systems that are being developed. And actually, one of those model systems is this organoid system that was developed in our lab. And in Dave's lab now, it's being used to actually also answer some of these questions and see whether there are responses or differences in responses to therapies. When you compare organoids from African-American patients, for example, to that of other patients. And even in my own work, and as researchers, we should also think about representation in our own work. When we're trying to find that new pathway, we're trying to find, dependencies in tumor cells. Are we using samples that actually represent, that is inclusive from that perspective? And in my own work, what I try to do actually was the original organoids that we used for developing the antibodies. I made sure that it included organoids from African American patients that was actually derived at SUNY downstate. So I think it takes tremendous effort to answer that question, but also we should lean into these new models and really be very aware of that as researchers to make sure that we include this into our research. And the last part is what I mentioned during the talk, which is the CA19-9 thing, where just because of this SNPs in FU3 and other Lewis A determining SNPs, African Americans don't, like about 25% of African Americans actually cannot make CA19-9, which is a major tumor marker, right? And whereas about 10% of Caucasians cannot make it, and for Asians it's about 21% or so. And if you think about this in terms of how CA19-9 is used to follow the treatment response, obviously you can use you can look at the radiological response, but at the same time, having that small marker is actually helpful. And so for patients that don't have that cannot make that small marker, what are the alternatives? And obviously these tumor cells make a lot of antigens. And one of the things is if we're able to identify many of these antigens and see which ones also respond to the treatment in terms of being able to follow the treatment response, then we can better follow treatment response and have more parameters to follow that and more accurately in other patients that can't make CA19-9.
Awesome. Well, hey, Dr. Oni, Dr. Durr, it has been a pleasure moderating this session and having you both talk about pancreatic cancer in terms of detection. Dr. Oni's Topi bodies, very unique name, and also my mentor, Dr. Durr, who has definitely gone down this path of finding molecular targets to better treat pancreatic cancer. So both important topics, early detection and therapeutics, is going to be needed to help with that survival rate of pancreatic cancer patients. So thank you both very much. And thank you all for attending this session. I will turn it back to Laura for further instructions on the rest of the day.
Yes,
thanks again.
I just want to thank the speakers and moderators from the first two sessions. Amazing talks, leading to very interesting questions. This symposium will continue back at 12:30 when we have our keynote speaker, Dr. Edith Mitchell, giving us another hopefully exciting and inspiring talk.
Anyway, welcome to the audience and partners for this session. This session is the keynote speech. I would like to introduce Dr. John Carruthers from the University of Michigan to introduce the speaker, but I would like to say a few things about Dr. Carruthers myself. This is someone I've known for the past 7 years through, our NIH funding on the race ethnic differences in cancer biology. He was the lead of the external advisory board for the 5-year period of the NIH grant. He came to Downstate every year to make sure that we did the right thing. I'm so indebted to him and our colleagues. I already talked about Anthony Baines, who was part of that external advisory board together with Dr. Carruthers. So thank you from the bottom of our heart and your continuing presence in these conferences to make it very lovely. Dr. Carruthers is the John G. Searle Professor and Chair, Department of Internal Medicine at University of Michigan. He is just highly accomplished. He runs a department that has more than 900 doctors. This is one of the largest internal medicine departments in the country. He's a trained gastroenterologist himself, physician scientist. His focus is on the hereditary colon cancers. He's just a master in that area. He's heavily funded, nationally, internationally recognized. One of the things that I'm proud of, and I'm so happy that he got the award, was the first inaugural John G. Kral, MD, PhD Distinguished Mentor Award from SUNY Downstate Health Science University in 2019. This was one of our doctors who exemplified what mentorship is, and Dr. Carruthers helped some of the scholars in our research program to reach potential that we never even dreamed about. He is just a master of the being a mentor, being able to make transitions for scholars to get to their next levels of excellence. So for that reason, we are very happy to have him introduce today's keynote speaker, Dr. Edith Mitchell from Thomas Jefferson University. So now I invite Dr. Carruthers to do the introduction.
Thank you, Dr. Salafu, and it is certainly my pleasure to be associated with the P20 of your program and to help out anyone there with any mentorship. It's a pleasure, and thank you for that kind introduction. It is certainly my pleasure to introduce Dr. Edith Mitchell. I'll have to tell you, I gave a talk at her institution a few weeks ago, and she got to introduce me, so I'm returning the favor for her. And she's such a wonderful icon in the field of medical oncology. Dr. Mitchell is a clinical professor in the Department of Medicine and Medical Oncology at the Sidney Kimball Medical College at Thomas Jefferson University. She's also the Associate Director for Diversity Programs and Director of the Center to Eliminate Cancer Disparities for the Sidney Kimball Cancer Center there at Jefferson University. She has a extremely long history with oncology, but she started out with her bachelor's in biochemistry from Tennessee State and earned her medical degree from the Medical College of Virginia, which is now Virginia Commonwealth University in Richmond, Virginia. And interestingly, she spent some time in the military where she entered the Air Force, and she was commissioned through the Health Professions Scholarship Program and was on active duty, and all the way to the point where she is now a retired United States Air Force Brigadier General, and she was the first woman physician ever to be promoted to that rank. She did her internal medicine residency at Meharry Medical College and a fellowship in medical oncology at Georgetown University. She has longstanding interest in cancers, particularly as it relates to Disparities, breast, colorectal cancer, pancreatic cancers, and other GI malignancies. And she's been involved in development of new therapeutic regimens, new drug evaluation, and chemoradiation strategies, and patient selection and supportive care for patients, in particularly GI cancers. She's authored more than 150 articles and chapters. She has received many awards and grants. She has served on the NCI review panel, several review committees, clinical trial committees, and NCI disparities committees. She was selected to be a member of the NCI's Blue Ribbon Panel to advise the National Cancer Advisory Board and the then Vice President Biden's National Cancer Moonshot Initiative. And she began in 2019 as a service member for the President's Cancer Panel. And most recently, amongst her many accolades, was inducted into the Royal College of Physicians. I remember Dr. Mitchell in giving her presidential address when she was president of the National Medical Association several years ago. I mentioned she's a retired brigadier general, but she also has earned many military service medals and ribbons, including the Legion of Merit, Meritorious Service Award, Air Force Achievement and Commendation Medals, National Defense Service Medal, and Humanitarian Service Medal. I will say that Dr. Mitchell is one of the most wonderful people I've ever met, dedicated to her work, and really has made a difference. And I'm looking forward to her talk, her keynote talk today on improved survival in cancer, but continued disparities. Dr. Mitchell, it's such a pleasure to have you here, and thank you for being here today.
Thank you so much, Dr. Carruthers. It's always good to see you, work with you, and in our combined collaborative on improving care and research in cancer patients, several GI malignancies. And after I was busy with various cancers, I proposed to Jefferson that I should have a center to eliminate cancer disparities. And that's what I am working on, not only the GI malignancies, but I had the pleasure of being with President Biden just a few weeks ago, where he launched his reimagined cancer moonshot and encouraging everybody in America to take a part of it. So what I've decided to talk about today is looking at some of the contributing factors to barriers in cancer therapy and cancer research, but also particularly those barriers that affect the most significant population in terms of cancer mortality. So join me as I talk about cancer survival and continued disparities. We're planning the future with precision medicine, looking forward to the future, but assessing the past through the rear view mirror. Oops, this is not working.
Just click on the background and then push your arrow. Try that.
Great, thank you. I have no disclosures related to the talk today. And our objectives are listed here. The poet James Baldwin said, know from whence you came. If you know whence you came, there's absolutely no limitations to where you can go. So as we evaluate disparities in cancer incidence and mortality rates, let's not forget the past, and therefore not forget those barriers that contribute to disparities. Of course, over the last few years, COVID has influenced a lot of media And it has allowed us to think about some of those disparities, not only in cancer, but in other healthcare disease processes as well. So COVID did give us some media presence with the disproportionate involvement of a number of healthcare processes with African Americans and other minority populations disproportionately sharing the burden of disease. Now, when we think about when the slaves first arrived in America, they arrived here very sick with many disparities and many disease processes. And here we are over 400 years later, still talking about how slavery has influenced the disparities in the healthcare system. And of course, Reverend Dr. Martin Luther King said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Another area, Dr. Carruthers mentioned the National Medical Association. And of course, it is the largest healthcare organization for physicians and other health professionals in the United States. It was founded in 1895 after Black doctors had been denied membership in a number of medical societies. And it was in 2008 that the American Medical Association, which I'm a member of, apologized to Black doctors for denial of membership over many decades. So National Medical Association is very important. It is still a supporter of healthcare for African-American physicians and their patients. Another area that we don't think about so much as influencing disparities in healthcare delivery, the Flexner Report of 1910 is one of the major contributors to disparities in this country because it set the culture. It was a landmark report that ended up closing 7 Black medical schools. So therefore only 2 left, Howard and Meharry. And this allowed for no place for the students of who are of Black descent for entering medical schools because the majority medical schools did not open their doors to Blacks extensively until the late 90s or the late 60s with President Johnson's Great Society. So the Flexner Report was really responsible for the low number of Black physicians in this country for many decades. Now, there is another part that was not mentioned very much in the literature, but the Flexner Report contains information written. Blacks should be trained in hygiene rather than surgery and specialties, and should mainly serve as sanitarians whose purpose was protecting whites from diseases like tuberculosis. Now, I will say the 3 doctors who have appeared on this program today, Dr. Salafu, Dr. Carruthers, Dr. Mitchell, can you think of us as only sanitarians? But this set the culture for medical education in this country and still is an important part of the culture of our medical schools. So therefore, it's so important for us to get rid of some of this information so that we can continue the progress and amplify the progress, enhance the progress of getting more doctors who look like us in this country. Another area that was very important for cancer was the National Cancer Act of 1971. And here we see former President Nixon signing that legislation. And in December of 2021, there was 50 years of celebration of this act, which provided for our National Cancer Research Program, our clinical trials programs, the cooperative group programs, our centers of designation by the National Cancer Institute, which there are 71 now. So the National Cancer Program really made a difference. Another person that we don't hear about very much, but who Dr. Carruthers and I have been the speakers for the Jane Cook Wright MD Symposium from AACR. Dr. Wright was one of the founding members of ASCO, and previously in years, we heard about the founding fathers of ASCO. Dr. Wright was the secretary, but she was also a member, and it was Dr. Wright that indicated that if we are to develop strategies for treating patients, that we needed to study their tumors in the laboratory. And here we are giving Dr. Wright, combined with members of ASCO and the National Medical Association, giving Dr. Wright the Legacy of Life Award from ASCO and from the National Medical Association. Not only was she involved with medical research, she was a superb clinician and involved in health policy. And here is her father, who was also Dr. Wright, who was a surgeon, graduated from Harvard, who was president of the board of the NAACP, and who advised former President Roosevelt to stop building those hospitals that were separate and unequal. There was no point in that. He was an advisor on the Hill-Burton Act and is probably responsible for more of the, or elimination of the Black hospitals around the country because of his separate and unequal and being a proponent for that. Another area of importance, that of the signing of the Medicare bill. Usually we think of bills being signed in the Oval Office, but former President Johnson elected to fly to Kansas City, signed the bill in the Truman Library, giving former President Truman the recognition of the first president to advise Congress and to request from Congress funding for medical care for the over 65 population. And after signing the bill, he presented former President Truman and his wife, former First Lady Bess Truman, the first two Medicare cards. Well, why do we think about Medicare as being a contributing factor to disparities in healthcare? It is actually the elimination of those and elimination of healthcare facilities with entrances, one saying colored and the other saying whites only. Now, why was this? Because the Civil Rights Act was passed in 1964. And within the Civil Rights Act is documentation of recommendations that no facility was to receive federal funds unless they adhered to the Civil Rights Act. So it resulted in desegregation of healthcare facilities where Black doctors were admitted to hospital staffs, waiting rooms were desegregated, hospital floors desegregated, and therefore desegregation of healthcare facilities. But more importantly, I shouldn't say more importantly, it's all related. It narrowed the differences in hospitalization between Blacks and whites in this country, allowing more Blacks to have access to coverage for medical care. from a publication that my friend Robin Hertz and I published. And I'll just give you one bit of information from Ed. And this evaluates the coverage of healthcare for cancer among populations. And what is noted that there is a much higher coverage of healthcare for individuals 40 to 64 from private insurance. And noting that in Blacks, 21% coverage by Medicaid, but only 3.5% in whites, having coverage for health cancer care. Note in the Medicare population and those over age 65 and eligible for Medicare, note that Medicare coverage is higher for whites than Blacks, and still Medicaid covering 15% of care for Blacks and less than 1% for whites. So there are differences in the coverage of cancer care by Medicare. My friend Dr. Freeman indicated that yes, genes are responsible for cancers, but there can be areas that influence the gene environment, therefore accounting for higher numbers of cancers and an increased incidence and mortality rate in Blacks. And if we are to make any headway into this, we needed to cover everything from prevention through survival and mortality. Now, why is this important? And why is it important to study cancer in Blacks? This is from the AAMC, indicating that if you look at people over 18 years of age, that at the time of this report, 68% were Caucasians. But if you evaluated those under 18 years, note that that number for Caucasians had decreased to 56%. And there were increases in the population of minority, racial, and ethnic groups. And consequently, there was a recommendation to address these differences in medical education. And the Accreditation Council for Graduate Medical Education also noted similar findings, that the number of Black and Hispanic physicians in this country was stable over multiple decades. And if we're going to change our competencies in education, we needed more Black and Hispanic doctors in America. And the recommendation was that we do something about healthcare disparities by increasing the number of Black doctors in this country. And the goal of workforce diversity was to achieve health equity, and diversity and equity was the way of doing so. So the DEI recommending that we look at the workforce, the outcomes, culture through diversity, equity, and inclusion, that we needed to contextualize the issue, own up to the issue, and using our smart information and skill building to build the information, build a plan, evaluate the plan, and show that equity matters. And the recommendation was innovative strategies to face the barriers, devise solutions, and then implementing these in our healthcare institutions, with the idea that there were inequities in the system, and we tried to evaluate equity, but note that the tree is bending in a direction of certain groups, and other groups left with no fruit on the tree and a bent tree away from their individuals. Yes, we could say equity. We give the marginalized individuals more resources, but there's still no fruit on the tree and it's bending. So what we need to do in our healthcare institutions is thus prop up the tree so it's no longer bending away from individuals, allowing for sunlight and resources to make sure there is more fruit and more resources available to the marginalized populations. So we then look at racial differences in cancer. I've mentioned that with the National Cancer Act, for many years, we only collected data through SEER and other agencies regarding Black and white patients. But over the years, more racial and ethnic groups were added to the data collection process. But what we note is that for this entire time, although there's a decline in cancer death rates and cancer mortality, African Americans still experience the highest rates of cancer mortality among groups in this country. And this is one example of African American men. And note that of all the groups where data are collected, African American men have a higher incidence rate and a higher mortality rate. For women, note that non-Hispanic white women have higher incidence rates reported, but African American men, or African American women, sorry, have higher mortality rates. And thus, over many years, we can see for many different cancers that there has been a decline in both men and women. So when it comes to breast cancer, note that African Americans have higher mortality rates, advanced cancer stage distribution at the time of diagnosis, and until recently, lower lifetime incidence. Younger age of distribution of Black women with breast cancer and an increased frequency of those adverse tumor features of the disease with more poorly differentiated tumors and triple negative breast cancer, but also remembering that there's a higher incidence of male breast cancer in African Americans. And of course, the genetics are there, and we know about triple negative breast cancer in others. However, there are other social determinants of health that can affect the tumor biology and genetics, thus contributing to the overall death rate. When one notices and measures the breast cancers that have a lower risk of recurrence, note that they occur more highly in white women, but triple negative breast cancer more than double the rate of triple negative breast cancer in whites in this country. There has been a recommendation that mammograms should be started by age 50. And what I want you to note that breast cancers are more frequently observed in younger women. And if one started mammography screening at age 50, these individuals would have been eliminated from the opportunities of screening. So the recommendations are age 40, not age 50 for initiation. And what do we mean by triple negative breast cancer? There's no expression of estrogen, progesterone, or the ERB2 markers. It occurs in about 15% of cancers, of all breast cancers, but in African Americans, in some areas of the country, this number is 39 to 40%. In our reports from Philadelphia, it was 20%. So these are more aggressive tumors. None of the anti-estrogens or other immunotherapies against ERB2 are effective, and consequently, chemotherapy is the main treatment option. It occurs more frequently in young women, African Americans, Hispanics, and those with BRCA mutations. So a lot of research ongoing there. Now, another area of concern that I've spent quite a bit of time on is that of multiple myeloma. And while we talk about disparities in the incidence and mortality rates of many cancers, including those of the GI tract, multiple myeloma is the most disparate of all cancers. Note that for incidence in racial and ethnic groups, that African Americans have more than twice the incidence rate of any other racial or ethnic group. And the same is true for mortality. Note the other racial and ethnic groups in the United States for which we collect data, and African Americans here being more than twice, having the more than twice the mortality rate. So a lot of research is ongoing in myelomas, and that includes some of the effects on the GI tract with proteins and others in the GI tract causing problems. But one thing is noted is that this pre-myeloma condition that is benign, MGUS, monoclonal gammopathy of unknown significance, occurs more frequently in Blacks, and it has even been described in children as low as age 10. What are the factors that lead to disease progression and malignant features, and then finally to multiple myeloma? So a lot of research ongoing to try and understand this progression from a benign condition through the development of myeloma, and the importance of this process. So a lot of research ongoing. What is noted in research is that there may be some differences in the genomic factors, and the genomic factors that predict risk of response to the newer drugs may be higher in these individuals with Blacks. So therefore, the inclusion of Blacks in the clinical trials, a very important idea. For GI malignancies, there are similar factors, and obviously I can't talk about all of these GI malignancies, but I focus on colorectal cancer. And yes, this is Colorectal Cancer Month, with Blacks having the highest incidence and mortality rates of other groups in the country. And these are data that have been reported in cancer incidence rates. Note that there has been a significant decline in these rates, but still marked differences between Blacks and whites in the country. Similarly, for mortality rates, differences between Blacks and whites, yet a continuous decline. And we've also seen colorectal cancer increasing in young individuals under age 50. And note there has been a 51% increase in these individuals in the country. So younger individuals presenting with significant colorectal cancer. And again, these are just some of the data that show that colorectal cancer in young adults younger than age 50 have increased and have actually doubled from 1990 to 2015. Thus, the recommendations from many groups, including American Cancer Society, the National Cancer Institute, and others, that screening should occur in, first it was the younger Black patients, but now for everyone, screening should occur by age 45. With the COVID pandemic, there were changes, of course, in our healthcare institutions based on the number of patients with COVID-19, and consequently, screening for many cancers decreased over the initiation of the pandemic. But with modeling data, the National Cancer Institute and Dr. Sharpless have indicated that there may be increases in cancers in the next 3 years because of this effect on screening for colorectal, breast, and cervical cancer. And in fact, for cervical cancer, there are also extensive recommendations for screening and treating patients early. With the modeling data, it indicates that we could actually eliminate cervical cancer or advanced cervical cancer in this country. So how can we affect the disparities? Community engagement and outreach, and increase in clinical trial participation, and other factors that could lead to more extensive genomic classifications and clinical research to allow full benefit of precision medicine, and that it should occur for all racial, ethnic, and socioeconomic groups in the country. So better use of and more research on precision medicine for the future. And from the University of Pennsylvania, it has been recognized that we need to really fix and correct those assumptions made on other individuals as we do research, because all of these factors can lead to misdiagnosis, inappropriate management, and therefore loss of opportunities for patients to participate in clinical trials. There was a large study conducted on patient-reported outcomes and surveys on patients about why they didn't participate in clinical trials. The most frequent reply from 80% of Black patients was that nobody ever asked. They wanted to participate in clinical trials, but were not invited to do so. And consequently, we need to understand this bias that, and the assumption that Blacks don't want to participate. They do. But with medical processes in the healthcare system, they're not invited. So we need to fix this in our institutions and make sure we are utilizing community engagement and outreach to enhance the clinical trial participation for patients with cancer, and thereby allowing more people to participate. And why is that true? Well, for NIH clinical trials, African Americans account for only 6.7% of participants. And for those processes that are brought forth to the FDA for approval, African Americans account for only 1.6%, Hispanic population accounting for 2.7% of FDA novel drug trials, and other minority groups, including Asian American, Native Hawaiian, Native Americans, only about 1% of participants in FDA novel drug trials. So we need to increase this participation so that we understand these drug combinations and drugs and other therapeutic interventions in all people in the United States. There are a number of root causes of disparities, and they're multifactorial. Few minority professionals, research studies not being included, lower rates of insurance, and out-of-pocket costs, the social determinants of health, and redlining in our cities that has allowed for healthcare deserts where there are not institutions that permit access to health care. The ACA has been evaluated, and in those states, it was reported in 2018, with Medicaid expansion, allowed for opportunities for patients that resulted in the fact that implementation of Medicaid expansions allowed for improved access to care for African Americans, and therefore more timely receipt of cancer diagnostic procedures, colonoscopy, et cetera, and therapeutic interventions, which reduce the racial disparities in access to care. So ACA being very important. This is a representation of what we have established at Jefferson and the Sidney Kimmel Cancer Center, making sure that we're taking advantage of community outreach, our navigators and community workers, partnerships, making sure we are including this in our basic science, clinical science, and our data collection and evaluation to make sure we are focused on the populations in our catchment area and therefore importance. Another area of research is that of the All of Us program from NIH. It is intended to collect information on 1 million individuals, and therefore not necessarily those who have evidence of cancer, evidence of other disease processes, but as a preventive strategy by determining risk and therefore providing this to the participants. And note that I don't say patients here because many of these individuals have no evidence of disease processes. It was initiated in May of 2018, and already more than 400,000 participants collected so far, and more than 50% of the participants are members of minority groups. And to this date, this is the largest NIH study showing participation of minority communities. Now, it's not only important for patients and participants, but it's also important for researchers because this gives the largest study where there are samples, biological samples for review and research, as well as the clinical data. All of Us is now accepting proposals from researchers. So it's one of the richest collections of data as well as biological specimen in the United States. So I encourage researchers to consider evaluation of All of Us and whether there might be an opportunity for research in your area of expertise and research. Another from the president recently, where he indicated that he was reigniting the cancer moonshot to end cancer as we know it. And he encourages all Americans to play a role in this. And his goal was to reduce cancer death rate by at least 50% over the next 25 years and improving the experience of patients living with cancer. And that was my last slide to say that we are all therefore working on decreasing our cancer death rates in this country, and especially working with populations, and therefore the opportunity for all of us to work together. So that was, I actually had just a final slide. So thank you so much. I'm so sorry about the technology, but I suddenly lost all connections. So thank you so much, Dr. Salafu, for the opportunity to speak with the group today. Thank you, Dr. Carruthers, for the lovely introduction that I hope my mother was looking down on.
Wow.
But thank you,
is.
thank you. And if there's time, Laura, I'm happy to answer a few questions.
Sure, we'll be able to take questions. So Laura, I believe they have to put it in the Q&A, or they're going to put it in the chat.
If anyone has any questions, please put it in the chat.
Okay, so we'll watch that. I just want to thank Dr. Mitchell for a wonderful talk and giving us a little of the history that has set us up into this, everything from slavery to the Flexner report to the wonderful contributions of Jane Cook Wright, and then showing us the importance of equity and justice. And maybe I'll start off with a question. You so eloquently put together many of the things that are doing at Jefferson for outreach to try to get people into clinical trials. And you had the nice wheel and involvement of, you mentioned navigators, partnerships, and even basic science. Does in your group, do you push education? And the reason I asked that on this, from even the students and multidisciplinary students, medical students, nursing students as well. The reason I asked this, I just recall that one article in the New England Journal of Medicine from a Harvard medical student that many of the images shown in medical school are on one skin color, and then you look at it on another skin color and the lesion looks slightly different. And I know there's been a push by some medical students, for instance, to show diversity of lesions from a variety of different backgrounds. So I was just wondering if for your outreach, does this get down to the educational level as well?
Oh, thank you so much for that question. And yes, we do have students involved, as well as those responsible for the education programs. And there have been some changes made. We also, in the Cancer Center, mentor students to try and increase the number of individuals interested in cancer-related fields, and particularly for African-American and other minority students, because while I presented data from ACGME on the practicing clinicians, what we have in cancer medicine, whether it's radiation therapy or medical oncology, is even fewer participating clinicians of disparate minority groups. So we started that at Jefferson, working with our students, and we have expanded that to the NCI-supported ECOG Akron Cancer Research Group. And I now have an NMA panel for ECOG Akron to have input from Black doctors, members of NMA, but also I started a program with ECOG Akron's support for medical students and residents attending the ECOG Akron meeting. So for this year, we're going back to in-person meetings, and we have funding to allow for 10 students who are from minority backgrounds to attend the ECOG Akron meeting, so that they can meet not only Jefferson faculty, but faculty and researchers from the NCI and all over the country, so that we are influencing individuals to pursue careers in medicine. The NMA also has a similar program in the Cobb Research Institute, and Dr. Griffin Rogers from NIH, who you know, has been doing this program for residents and fellows for many years, and I participate in that. So it's collaboration among individuals in research, in clinical trials research, to try and mentor more minority students in this aspect of care. So our meeting is in Chicago in the first weekend in May, and we have received funding from NCI and the ECOG-ACRIN Cancer Research Group for 10 students to attend the ECOG meeting. So we're continuing collaboration with many around the country, those of us at Jefferson, but we actually started this program at Jefferson.
All right, wonderful. There's a question in the Q&A from Camille Claire. She thanks you for your presentation, and she asks, how can primary care physicians and obstetrician gynecologists in particular increase cancer screening and clinical trial entry?
So thank you, Dr. Claire, for that question. And again, we are working to increase screening. And that was the topic of the President's Cancer Panel report. And for ECOG-ACRIN, we are designing methodology to have not only cancer treatment related committees, but a primary care physician committee to increase screening for various cancers and thereby have research in this area. And as I mentioned before, with the screening for and treatments, as well as preventive strategies for cervical cancer, we should not have women dying of advanced cervical cancer in the country. So we're planning to begin committees for primary care physicians who can assist us with research on screening.
Thank you. There's a question from our own Antonio Baines, and this is a general question. Why do you think we still have a disparity in diversity of physicians and scientists here in 2022?
So thank you so much, Antonio, for that question. And I think it goes back to the fact that many African-American physicians early on in this country were denied membership in various societies, that with the 1910 Flexner report, medical schools were closed, 7, leaving only Meharry and Howard, and other majority medical schools not increasing the numbers of Black students at that time. So for many decades, we had a diminution in the number of African-Americans physicians produced in this country. And therefore, that is one area. We have education programs that have not influenced Blacks to go into fields of medicine. In fact, when I was growing up, I was told there are not many Black women doctors. You should make sure you get a teaching certificate. And others who give similar stories of not being encouraged by high schools to enter fields of medicine. Now we have the STEM programs that are making headway into that area. Many medical schools participating in STEM-related education programs, STEM-related programs being taught in schools. And now there are competing efforts from other career fields where the cost of medical education is shown as a barrier to these individuals because they can make much more money in careers that do not require as much time and effort as medicine. So I think all of those areas, there are medical schools now evaluating 3-year programs toward medicine, and others combining an undergraduate education with the medical studies so that students are able to proceed to receiving a medical degree in a shorter period of time. So lots of research ongoing between education institutions, undergraduate studies with that of the graduate studies. Jefferson has a 6-year program with Penn State. Tennessee State, where I attended undergraduate, has a combined program with Meharry, where students spend 3 years at TSU and then go to medical school. And there are many others in different parts of the country. So lots of research to try and address the barriers to African-American students participating in graduate medical programs.
Well, Dr. Mitchell, because we're at time, even though there's a few more questions, but because of the time, I want to thank you for your outstanding presentation, the many tidbits you've given us and how the journey has happened and where we can go from here. And we gotta work hard at making sure that there's elimination of these disparities. So I want to really thank you for your presence here today. Thank you so kindly.
Thank you so much, Dr. Carruthers, and thank you, Dr. Salafu, for the invitation to present today. I'm most appreciative and appreciative to the audience for attending.
Thanks. I'll turn it back over to Dr. Salafu.
All right, very nice. Thank you very much, Dr. Mitchell. That was phenomenal, very powerful talk addressing all the issues that are of essence today. All right, so we now move on to the next session, the last session, which is session 3. Session 3 is going to focus on cancer and comorbidities, modifiable risk factors. This is a topic that is probably going to be visible and more connecting to a lot of audiences because of the nature of the topics. So I'm hoping that we can get more discussion around that at the end. The moderator for this session is going to be Dr. Kitao Demisi. Dr. Demisi is Dean of the School of Public Health at SUNY Downstate Health Sciences University. Dr. Demisi is one of the academic scientists, population scientists, public health experts of our decade and in the country right now, who is serving as our Dean of the College of Medicine. He has tremendous impacts on health disparities, minority health, perinatal health, and also in cancer. He's funded heavily by the NIH for various projects, including breast cancer. So he has a huge, knowledge base in cancer and comorbidities around cancer. So he's really the right person to moderate this session for us. So please join me in welcoming Dr. Kitao Demisi to this session, and he will then introduce the rest of the speakers for the session. So thank you, Dr. Demisi.
Thank you. Thank you, Dr. Salafu, for introducing myself and also introducing the session. Like previous panels, we'll be taking questions and discussions at the end of the 3 presentations. We have 3 presentations in this session, and all of them are tied with comorbidities and modifiable risk factors. And our first speaker, which I would be very happy to introduce, is Dr. Kerry Daniel McDougall, who is an associate professor in the Department of Epidemiology at the University of Texas, MD Anderson Cancer Center. Dr. McDougall earned her BS degree from University of Arizona in molecular and cellular biology, her MPH from Emory Rollins School of Public Health in Atlanta, and her PhD in nutrition and health sciences again from Emory. She also served as a research fellow in the Division of Cancer Epidemiology and Genetics at the National Cancer Institute. So her presentation will be navy beans, an accessible prebiotic food source, shifts the microbiome and blood metabolome of high-risk patients in the BE-GONE trial. And I welcome Dr. Daniel McDougall to start her presentation. Thank you.
All right, thank you so much for that introduction. Just give me 1 minute to kind of move things around so I can see my own presentation. Thank you so much for the invitation, and we'll go ahead and get started. A lot of us already know that colorectal cancer is one particular space where diet, obesity, inflammation, some of the things that plague many Americans today, is important for modulating risk. But I also want to bring your attention to there's growing understanding that this is important for colorectal cancer outcomes. So survival, recurrence, progression of disease. This is an area that I've become increasingly interested in working in a cancer center, as there are not very many healthy individuals walking around. And so we've done quite a bit of work to try to understand what's going on in our patient population and to understand whether what we recommend for risk and prevention might also be beneficial or need to be tweaked somewhat in this group. One thing that we know about the human microbiome is that it is causally, etiologically at least, possibly causally linked to the development of colorectal cancer. It's also been hugely important in the news lately by our group and others as being critically important to response to immunotherapy and other modern cancer therapies that our patients are being put on. And of course, the microbiome really stands also at the interface of the foods that we eat, the dietary patterns and the dietary habits that we have, and how that impacts our human health. But there are numerous challenges and considerations before we tell a patient what is the best way to fix your microbiome in terms of improving your response to therapy, your overall outcomes, your survival. These are questions that patients want to know. And often one of the things they want to know is, what should I eat now that I already have cancer? Telling them how they got the cancer based on what they eat is not productive at that point. And so if a patient presents with a precancerous polyp in their colon or has recently completed their colorectal cancer therapy and wants to move forward and not get colorectal cancer or another type of cancer again, what do we tell them? And so this is not going to be an easy nut to crack or an easy problem to tackle. However, we do know that prebiotics are increasingly interesting, but these are supplements, sometimes in supplement form, and it's something that might not have the same effect when we take it out of whole foods. That is a long learned lesson actually from the field of nutrition and dietary supplements in the space of cancer risk and prevention. And it probably is important here as well. The other thing is that diet could have these holistic changes, but there are so many variables, including how do you get people to make these changes? How do you get them to sustain these changes? And based on everyone's different host metabolism, microbiome, are they going to have the same effect? So there are multiple challenges. The BE-GONE trial was trying to address some of this in that we took a prebiotic whole food source, which was dry beans. And when I say prebiotic, the kinds of things that a prebiotic food has is soluble and insoluble fiber and resistant starch that actually get down to the colon and have specific effects right there. They survive digestion, right? And then soluble fiber also creates a gel within the colon. And then essential amino acids that the microbiome actually helps get to where they need to go for the host, polyphenols, and other bioactive compounds. So again, this sort of holistic effect that comes with the food of things that impact the microbiome and things that impact the host that may have this sort of holistic benefit. And of course, once someone has survived colorectal cancer or shows up with a precancerous polyp, they're not just concerned, or shouldn't just be concerned, about cancer. They should also be concerned about cardiovascular disease and their overall cardiometabolic health, because one of those two things is going to be the cause of death for most of us in the United States. And so we tested the impact of this relatively simple intervention, and we looked at a little bit less simple gut microbiota and blood profiles as the outcome in high-risk colorectal patients that we let otherwise consume their usual diet. So why did we choose beans? Lots of reasons. Again, they're a natural prebiotic food source. They come on a shelf in a can. But also there was some scientific backing behind this. The polyp prevention trial, which was a low-fat, high-fiber, high-fruit and vegetable, like overall lifestyle or overall dietary change, not just lifestyle, but dietary change, that targeted adenoma recurrence. Interestingly, there was no difference in the two arms. However, compliance was low. They did actually see something in super compliers, but very few people could actually maintain those recommendations over time. But when they looked at the trial as a cohort, they saw that those in the highest versus lowest intake of a change in dry bean intake as part of the intervention actually had a reduced risk of adenoma recurrence. Then on the side of cardiovascular disease and cardiometabolic markers, there's been many dry bean interventions or dry bean rich dietary patterns that also show improvements in LDL and other cardiometabolic markers. So this patient population was patients who had a high-risk BMI or waist circumference, had a history of colorectal cancer. So they could be just coming off treatment as long as their bowel habits had returned to normal. And then we also recruited patients who are what I call repeat offenders of the precancerous colorectal polyp domain. So individuals that are obviously have something going on with their gut health and possibly with their diet that are putting them at higher risk of developing colorectal cancer as well. And we block randomized patients to chronic disease medication status, as of course, if you're going to target a patient with a high-risk BMI or waist circumference, a lot of these patients are on statins and or metformin. So the BEACON trial was, like I said, relatively simple in terms of its intervention. There were only 2 arms that patients were randomized to, and it's a crossover without a washout, so it's actually a diet sequence. You have patients that go on to the control diet first, or you have patients that go on to the intervention diet first. The control diet is just the usual diet without dry beans, and the intervention diet is the usual diet adding dry beans. And we did this in a ramp up fashion to get patients acclimated to the beans, both in terms of GI side effects and also just incorporating it into their diet. And we did have dietitians working as the coordinators for this study to help patients do that. And of course, we assessed all their dietary habits, their body weight, and other lifestyle parameters that we monitored throughout the 20-week study. And we collected stool samples and fasting blood draws at our visits in the morning. And as you can see here on the your left, your right, I'm not sure, but over here, dry beans, a half cup is a portion or a serving size. So we're trying to get them to actually eat 2 serving sizes, but that really provides a lot of important nutrients for high-risk patients. It provides 16 grams of dietary fiber and a lot of other good quality micronutrients like calcium and iron and potassium. And we did use organic dry beans, navy beans, and canned, and they were just in water and sea salt. And so they were also very low in sodium, but a lot of patients would not eat not organic beans. And then all of our samples were processed either at MD Anderson for all the blood markers or the Center for Metagenomics and Microbiome Research at Baylor College of Medicine, both here in Houston, Texas. And we characterized the 16S ribosomal DNA for the microbiome. And we also did a CLIA cholesterol panel and about 704 plasma metabolites. And we conducted longitudinal analyses using generalized linear mixed models with a random intercept. And we collected about 249 of each of those types of samples over the study trial. So this trial is currently in submission. So we are certainly take the findings with a grain of salt. I mean, they are real findings, but we are continually honing how we analyze the data, how we present the results. So I wouldn't take this to the bank, nor would I share it broadly because it's not yet published. So we screened approximately 238 patients. We had 69 patients complete the pre-visit. Then we set those 69 patients onto the run-in. We had several drop out at that point for different reasons. One of the things that happened during this trial was Hurricane Harvey, which some of you may remember being a huge thing for Houston, not just when it happened, but for 1 to 2 years afterwards, people would drop off because of respiratory illness or because they were completely remodeling their home after Harvey. But we did successfully randomize 55 individuals and a total of 48 individuals completed the trial. Patients were more likely to drop out if they were randomized to the control first, which is maybe not totally unexpected. The mean age was 63 and the BMI average was 31. About half the participants were male. About 75% were survivors and the other quarter were precancerous polyp patients. 75% were white, non-Hispanic. 44% were on statins or metformin. We also did have more individuals on these medications tended to drop out for whatever reason. And of course, the pre-study dietary profiles, almost no one ate beans at any large frequency before joining the study. And here are also showing the baseline kind of microbiome features were not different between the two randomization groups, nor were a range of different demographic and dietary risk factors. So, of course, as everyone will wonder, did people like the beans? Did people have side effects from the beans? And like other trials, we saw about a third to 40% of our patients did, of course, report gas or bloating or a change in bowel habits. And of course, because we put people on beans and took them off beans, we had both loose stool and constipation in terms of changing those fiber levels. But again, we worked with our dietitians on the study and did our best to help these patients get through that. Also, many of these patients have had surgery on their bowel. We had some restrictions, of course, for bowel length because of the safety issues, but many of these patients had had surgery for their colorectal cancer as well. And we did see that people were more likely to report, slightly more likely to report these things if they were randomized to the intervention in the second part of the sequence. We didn't see any attributable conditions in those who withdrew post-randomization. They all withdrew for these other reasons. And about 95% of participants met our overall target, which was 28 beans consumed over 8 weeks. And about 75% met the weekly criteria, such that we had certain amounts of beans we wanted them to eat weekly. But sometimes people would miss a week for travel, for work, for various holidays, for things going on. So that was met by 74%. Just again, to remind everyone as we go to the results, everyone went through a run-in, then they were randomized, and then we measured stool microbiome at baseline or randomization, 4 weeks, 8 weeks. And then for those randomized to the beans first, they would return to the control in the second 8 weeks. Those randomized to the beans second would remain on control and then go on to the dry beans. And we also measured blood at each of these time points. Looking at the dietary assessments, we collected multiple 24-hour recalls or dietary interviews throughout the study, checking on them regularly in terms of compliance and also seeing how people were incorporating the beans into their diet. And I just put this little red line here because the dietary fiber recommendations in the US are actually quite unattainable for most individuals. It's 14 grams per 1,000 kilocalories. Now, this is 24-hour recalls, which sometimes underestimate true intake, but you can see that when patients were on the intervention, their total dietary fiber intake increased, which is not unsurprising, but patients were allowed to, eat the beans instead of something else, right? Because of the nature of the way the intervention was delivered. And of course, when they came off the beans, their dietary fiber quickly went down to their baseline levels. Same for individuals in the intervention second. Because we were not targeting it, but people always ask, do people gain or lose weight on this dietary intervention? And the answer to that is no. There was no effective BMI, weight, total energy intake, physical activity levels, those sorts of things on the intervention. All those were relatively flat and stable. Now, this is a little bit complicated to look at in a slide, but it's just an overall pattern that I want for y'all to take back. But this is a method where we looked at different fecal bacteria that are present in 80% of our population at baseline and looking at shifts in these bacteria over time. And here I'll just show you Faecalibacterium, for example. So when the patients are on the intervention, Faecalibacterium increases. That's the increase in red at 4 weeks and 8 weeks. And then as the patients come off the intervention, this is those randomized beans first, the Faecalibacterium immediately starts to drop. And you can kind of see that this is an effect for some other things as well, like Roseburia decreased, Streptococcus decreased, when patients went on to the intervention. If we look at overall effect estimates representing the change, we see again this sort of sigmoidal shape such that when patients remained on the control, we'll look at Faecalibacterium first, they didn't have much change. Then it went down a little bit. Again, the control diet is usual diet, avoid dry beans. And then of course, hang out with us, tell us all about what you're eating and meet with our dietitians. Faecalibacterium actually went down under those conditions, and the inverse Simpson index, which is an alpha diversity index that suggests that the microbiome has a more equal distribution of different bacteria, increased on the intervention, as did Faecalibacterium. But then again, when patients came off the intervention, Faecalibacterium significantly decreased. The inverse Simpson index, however, seemed to not decrease, at least as rapidly. This is just another method that we use to look at less prevalent bacteria. So statistically, it adds a constant, but some of these effects can be really driven by small amounts of individuals. And for that, we also saw that Bifidobacterium increased on the intervention and Collencella, a potential pathogenic bacteria, decreased on the intervention. And actually all these are P less than 0.05, which is highlighting a couple. So kind of looking at this overall, what was happening. Individual bacteria are fine and good, but really it's all about the pattern of changes that are occurring throughout the microbiome. And so what we believe we saw kind of looking across a lot of different bacteria was like a shift in fiber sources, was kind of changing which dominant fiber fermenting bacteria were present. So for example, like Roseburia went down, which is typically a bacteria that's involved in inulin or starch degradation. So maybe like whole grain products. What we saw go up was bacteria that like pectin, and other kind of general fiber fermenting bacteria also went up. But again, it also depends on what people had to start with. If you don't have something to start with, you can't necessarily increase it. So this is a real challenge when looking at microbiome data. Streptococcus, which is of course expected to be bad, went down quite rapidly early in the intervention, but when we look over the full 8-week period, there was no effect. So consistent with what we observed for individual bacteria and diversity, alpha diversity, we looked at whether there were community shifts or differences. So we look at basically the distance that someone moves within their community from baseline to any point in the study. And again, it's kind of reflecting more than one bacteria, were the shifts all summarized across these changes. And basically what we saw is that early in the intervention, people tended to shift a little bit more than after they kind of have been on the intervention for a while. Maybe they either sort of kind of settle and plateau into their own homeostasis, but then these shifts were kind of maintained such that even when people went onto the control, the overall community did not shift back. This is those to the intervention second. They had a little bit different effect where they kind of went up right away, and then that difference was maintained at 8 weeks. So just kind of an interesting trend to look at. We did not observe any significant decrease or improvement in LDL cholesterol. And that's not totally unexpected based on other previous trials, but of course it was something we were hoping for. That said, there's also a lot of intra-individual variation, within person variation in this trial, such that, again, what you have in terms of different bacteria, so each color is a type of bacteria. This person had Faecalibacterium, and you can really see the Faecalibacterium shifts over time. This person also actually had an improvement in their LDL levels and their LDL to HDL ratio. And they really significantly increase their fiber through the beans. So, maybe there are individuals who have a response and individuals who don't have a response based on the gut microbiome and based on kind of where they start. So this is something that we're continuing to look at deeply in the data, but it's very complicated. The other thing we have in our arsenal is the circulating metabolome. So one thought is, well, maybe LDL would decrease if this trial went on for more than 8 weeks. So maybe there are more short-term changes in the host metabolism that can kind of tell us whether we're having a beneficial effect, and to understand what the microbiome is actually doing that truly impacts the host. And so we had 5 metabolites that really passed our strict FDR adjustment criteria, because of course you're looking at 700 metabolites, it's a lot of tests. And what we saw was like picoleic acid and SAM increased, trigonelline and theophylline also increase, and then an indole metabolite decrease. I'll tell you a little bit more about those findings. And again, when we look at these metabolites over time, within each individual, we see that some people have really dramatic responses and some people have almost no response. And we see that sigmoidal shape, whereas they go up on the beans, it goes up at different rates in different individuals, and it comes down at different rates in individuals. So again, looking at the effect estimate, which kind of trying to summarize all these changes across individuals, we see that same relationship. Really no change on the control diet. When they're on the intervention, these metabolites go way up, but they don't necessarily experience a bigger change at 4 weeks and 8 weeks, which is sort of interesting in terms of how long we need to do something to see these effects. And then again, one of the more striking findings from this trial is in the group that was randomized to the intervention first, what happens when they return to the control? And these, drop possibly much more dramatically than they actually rise, which is something to think about when we are intervening in patients and then stopping the trial and walking away. So some of these metabolites are not in the least bit unexpected for dry bean trials. In fact, picoleic acid has been suggested to be like a nutritional metabolite marker of dry bean intake, fairly specific, because it's involved in the microbial metabolism of lysine. And of course, different SAM derivatives are methyl group donors and acceptors that have a lot of important chemopreventive and cancer modulating properties. But also they have specific action in the colon. So just to quickly summarize these findings, picoleic acid, again, anti-inflammatory, anti-tumor, antibiotic properties. There are actually picoleic acid blood drug derivatives. SAM is a well-known kind of ubiquitous cancer metabolite. It's the sole methyl group donor involved in the methylation of DNA and RNA and histones that modulate autophagy or cell death through epigenetic effects. And the findings for some of these alkaloids like trigonelin and theophylline might be related again to the action of SAM. So we know that SAM is involved in producing trigonelin. And we also know that theophylline is closely related to trigonelin and is important for HDAC activation, which is an important mechanism in colorectal cancer prevention. The decrease in the indole metabolite was also interesting, but not totally unexpected, as it tends to reflect shifts away from bacterial degradation of tryptophan by E. coli and other potential pathogens. So in conclusion, we really thought that the trial showed us that this is a safe and scalable intervention, that this is a viable prebiotic food source. We definitely saw targeted effects in the microbiome and in the host metabolism. And even though, the compliance data was pretty good, the intervention was, fairly simple, and it was 8 weeks long. And although we saw these shifts in metabolites, we did not see an improvement in some sort of clinically actionable marker like LDL. And maybe the trial needs to be longer or more impactful, or it needs to be targeted to people who are in worse shape to begin with. But adding about 2 servings of beans to the diet on all or most days of the week seems sufficient to balance or enrich the gut microbiome of our high-risk patients. And these could be patients who are, unwilling or unable to make or sustain more dramatic changes to their usual dietary pattern without significant support. And again, the thing that was most striking to me was how significant the effects of coming off the beans were. And that really made me start thinking, because we have been doing other work in active treatment patients with melanoma, where immunotherapy is strongly used. And we have these really high impact findings showing that Faecalibacterium is critical for response to PD-1 and other immunotherapies. And then we just recently published a paper, another paper, follow-up paper in Science, showing that dietary fiber intake was critically important to this relationship. And we started doing a full feeding study in these patients to look at whether we should, whether we can impact the microbiome in these patients, impact immune responses. And one of the things that's interesting is we successfully scaled everybody up to really high dietary fiber intake. But as soon as they walked away from the intervention, everybody went right back down or lower than their baseline fiber intake. And again, this is critically important if Faecalibacterium is something that you need to sustain in order to respond to your therapy. And that's a short window of time in the grand scheme of things. Development of cancer takes 10 years. Maybe your immunotherapy treatment could be as short as 12 weeks. So this is a big challenge in the field for all, behavior change, and particularly for diet. And I'll just end on this note again. There's still a lot of challenges here, but we're continuing to try to figure out, simpler ways that we can have an impactful change on the microbiome that's safe, that's effective, and that's scalable for patients. And I'd just like to thank everyone, but most importantly, the patients who ate the beans and gave us all their precious time and energy, and their families who put up with them during the intervention as well. Thank you.
Thank you. Thank you, for an outstanding presentation that was very informative, Dr. Daniels, McDougall. So if the audience have questions, please hold your questions to the end of the panel discussion, and you'll have an opportunity to discuss it at that time. Our next speaker is Dr. Marianne Banerjee, who is the program chief in the Division of Endocrinology and the director of Diabetes Treatment Center at SUNY Downstate Health Sciences University in the College of Medicine. Dr. Banerjee obtained her MD from Temple, and she did internal medicine residency at SUNY Downstate and a fellowship in endocrinology also at SUNY Downstate. And she's a professor of medicine at SUNY Downstate. So the presentation is the relationship of obesity and cancer. And it is my pleasure to present Dr. Marianne Banerjee for her presentation. Thank you.
So I want to thank all of you for inviting me and for the audience for being here. And Dr. Demisi, thank you for the introduction. So I have a talk that's a little bit to the side of what I usually talk about. And the outline for this talk will be a bit on the epidemiology of diabetes, obesity, and cancer, some potential mechanisms, and whether anti-diabetes medicines that we use potentially could increase the risk or decrease the risk of developing cancers. So diabetes is associated with an increased cancer risk. The talk is really diabetes, obesity, and cancer. And the outline is as follows: a bit on the epidemiology of diabetes, obesity, and cancer risk, some potential mechanisms, and whether anti-diabetes medicines increase the risk.
Can you click on the bottom to lodge in the screen?
Yeah, that one. The presentation mode.
Yes. Yeah. Okay, so the outline is as follows: epidemiology, potential mechanisms, and whether some of our anti-diabetes medicines increase or perhaps even decrease the risk of cancers. So diabetes is associated with a cancer risk, as all of you know, since most of you are the experts here. Liver cancer is increased, particularly among men and women. So is pancreas cancer, bladder cancer, colorectal, kidney. In men, prostate cancer is a little bit lower, but that's a very complicated statistic. And in women, endometrial and breast cancer are increased as well in diabetes. In terms of cancer mortality, according to the body mass index in the Women's Cancer Prevention Study, it showed an increase of various kinds of cancers. And in this slide, it's linked to the highest BMI category for each particular cancer that's listed on the left-hand axis. Again, with uterine cancer in women being the highest, kidney cancer next, cervical cancer, pancreatic cancer. And you can see breast cancer is also has a twofold relative risk of death in the presence in the highest BMI category. Turning now to men, the same data show similarly liver cancer being very high, pancreas being high, stomach, the GI carcinomas being elevated as well. And again, as I said, prostate cancer is at the bottom. Again, a more complicated calculus. So the obesity-related cancers, again, summarized here, giving you the relative risk with a BMI of about 25 to 30, colorectal in men and women, breast, postmenopausal breast cancer in women, endometrial, renal, esophageal, pancreas, gallbladder, and adenocarcinoma of the gastric cardia are increased. And these all increase with a relative risk that is higher in the presence of a BMI that is greater than 30. So the question is, if obesity is associated with all these cancers, can we affect it in any way? And the only way to affect obesity quickly and for some prolonged duration is through bariatric surgery, because as everyone knows, putting people on a diet is incredibly difficult to sustain, even if it's doable for a short term. So several studies, there are many studies, but several of them include the Utah Obesity Surgery Study, which was a retrospective cohort study, including a large number of patients, nearly 10,000 people with gastric bypass. And then they were matched with severely obese individuals whom they found through the Utah Driver's License Registry. All had a BMI of greater than 35. And what they found in this bariatric surgery group is that compared to the control group, the patients who had underwent the surgery after, I think this was a seven-year reporting, had decreased all-cause mortality was 37 versus 67. Cardiovascular disease was down. Diabetes was significantly down. So was cancer, and other diseases were not that remarkably lower. There were also unusually increases in non-disease causes of death, for example, accidents, poisoning, and suicide, which were different from the control group. Looked at longitudinally over the entire length of the study, the data looks like this. The adjusted hazard ratio is about 0.63, so there's a significant improvement in outcomes. And in the surgery group, particularly in the group that has a BMI greater than 45. These are the patients who did not have surgery, the registry groups, and these are the individuals who did have surgery, and they have done much better over time. If you look at all the subjects in the 7-year follow-up of this Utah study, which was mostly gastric bypass procedures compared to matched patients, there's a slight difference, but the study is essentially very similar in terms of the hazard ratio of all-cause death being 0.63 versus 0.60 in the matched subjects. And you can see that all deaths caused by various diseases were lower, particularly the cardiovascular disease, although heart failure and stroke were not particularly decreased. Diabetes was decreased greatly, so was cancer, as well as other diseases. Now, in another bariatric surgery study, the risk of cancer, again, was looked at in a very large multi-site study, looking at obesity versus non-obesity related cancers. And this one shows the difference between all cancers. As you can see, the individuals who did not have bypass had a higher death rate. Obesity-associated cancers did much better, but cancers that are not known to be associated with obesity did not have any particularly significant changes or improvements. And this is relatively recent data on bariatric surgery. So they've pointed out that the risk of cancer then was significantly improved, as you can see on this hazard ratio diagram. Particularly colon cancer, endometrial cancer are on the left-hand side, are lower than the individuals who did not undergo bariatric surgery. Kidney cancer is not significant, but it is one of the obesity-related cancers. Pancreatic cancer was improved, and postmenopausal breast cancer was improved. Now, in contrast to the data on cancer and bariatric surgery, which doesn't seem to me, it seems it goes in the right direction for the most part, but is not as striking as if you look at the effect of bariatric surgery on the treatment of diabetes. And this is 5-year outcome, in which you can see that on the upper left-hand side, they compared gastric bypass to sleeve gastrectomy and to medical therapy. And you can see that the glycated A1C is best served by the patients who have a gastric bypass. The body mass, the diabetes improves remarkably in patients who have gastric bypass compared to sleeve gastrectomy and as well as medical therapy. The body mass index decreases the most in gastric bypass and less so in both of these surgical cases, but not particularly great, not as greatly as in the patients with medical therapy. And the data here is much simpler. Many of the patients do improve. With cancer, it is a much more difficult thing to identify who is going to improve when you start. Now, as you have already probably described, there are tremendous racial differences in obesity and cancer. And I simply put this up here just to point out that their cancer death rates are higher for Black women, and they have a much greater degree of obesity than white women, who are the benchmark for this in this particular case. And the question is, why is that and what can be done about it? I would just like to parenthetically add a little bit of our own data from SUNY Downstate, but just in one slide, to point out the tremendous heterogeneity in type 2 diabetes among our African American population here, in that there are not just insulin resistant variants, even though many of the patients will be obese, but within this obese group, there are both normally insulin sensitive patients as well as insulin resistant patients. And when you think about insulin resistance and type 2 diabetes, one thinks of patients with high cardiovascular risk, high cancer risk, and the usual phenotype includes hyperinsulinemia, elevated insulin levels, increased adipose tissue in general, high organ fat from visceral to pericardial to liver fat, and high lipids, which you might think of as circulating fat. And although these are the dominant forms in our African American population here, there's also a very strong other form of normally insulin sensitive variants where they have no cardiovascular risk factors. And I don't know that anyone has ever looked at, including us, whether there are any differences in cancer risk factors between these two phenotypes, the insulin sensitive and the insulin resistant. So that is something that we should and might want to look into. So I'm going to move on to thinking about how do we think about the clustering of these various metabolic diseases, because I never thought of cancer as a metabolic disease, but I think it is. If you have obesity at the center, the disorders on the left-hand side include insulin resistance, which we just mentioned. If you are obese, your glucose does not get transported into your cells. And so the body, as a reaction, increases the amount of insulin. And that increase in insulin may have other downstream ramifications that are adverse to the organism in general. But the metabolic problems from obesity include, as I said, resistance, type 2 diabetes, the fatty liver, atherosclerosis, hypertension, and stroke. On the right-hand side are the other cluster of diseases such as cancer, asthma, sleep apnea, osteoarthritis, neurodegeneration, and gallbladder disease. And of course, all this leads to premature death. And the question is, how does this actually happen? And the true answer is we don't really know how it happens. But many people have put together complex diagrams such as this to ask what's going on an intracellular level. And if you look a little bit, so these are really potential mechanisms. We don't really know if these mechanisms are in fact functional for the most part. But if you look on the left-hand side with type 2 diabetes being a result for the most part of obesity and insulin resistance, and then the development of hyperinsulinemia, eventually hyperglycemia, because many people with obesity, simple obesity, are hyperinsulinemic, and the hyperglycemia is adverse in terms of it promotes tumor growth. The hyperinsulinemia coming around this way interacts with the insulin receptor antibodies, and post-receptor in these cells are mitogenic. There are mitogenic pathways within the tumor cells which promote tumor growth as well. So not only is it glucose, but there's also insulin. There are also insulin-like growth insulin growth factor binding proteins, which also promote tumor growth in addition. So many things converge to create tumor growth. And as our previous speaker so elegantly described, there are factors from the intestinal microbiome that are also contributing to all this. Moving to the right-hand side, obesity, particularly in adipose tissue, well, that is obesity. There are macrophages, and macrophages produce an enormous number of inflammatory parameters and markers that you can see here, only one of them being TNF-alpha. And these contribute also to tumor growth. And furthermore, you have aromatases and estrogens change. And if you have an estrogen sensitive tumor, such as breast cancer, that can also get accelerated and increased. This particular kind of a diagram can get incredibly complex, and some people work on very detailed strands of it all. The big question from something like this concept is, does it really apply, and how does it apply to individuals with cancer, and which of all of these things is the central nugget of the problem? So some people have taken some of these and to take just the fasting insulin, which is elevated in obesity and in obese diabetes, and looked at outcomes in early stage breast cancer. And this is a prospective cohort study. And they divided up the insulins that the patients had into 4 quartiles. And you can see that the ones with the highest quartile had the largest recurrence of the lowest recurrent disease-free, the lowest disease-free survival. And so that's one thing. And then the other issue is they've plotted the BMI across on this axis, and you can see it's not quite linear because most biological systems are not, but it gave people a tremendous sense of the fact that yes, hyperinsulinemia may be a cause of particularly breast cancer. They also had some early data in 22 patients showing that if they treated patients, for example, with metformin, maybe they could lower the insulins and perhaps have better outcomes. Pancreatic cancer also is associated with elevated insulin levels, as you can see over here. And the question here again is, does decreasing the insulin levels actually improve outcomes? And how might we do that? A little bit on colon cancer cells. These are, this is again, actually these are human colon cancer cells, but asking, can you modify the various, can you add glucose to some of them? Can you add IGF-1 and IGF-2 or insulin, which are key mediators in type 2 diabetes, and ask, does it change anything? So what they found was if they added glucose, only early stage, these are Duke stage A, B, C, and D, only the early stage glucoses, actually glucose increases the DNA content of early stage colon cancers, but not in the later stages B, C, and D. In contrast, however, if you add IGF-1 or insulin or IGF-2, the later stages of cancer, this is B and C at the bottom over here, actually increase, but not the early stages. So this is some basic science data to perhaps guide us. This was published very recently this year, last year, but the question is, how do we actually implement this? Other basic science data shows you that if you create a mouse model and silence the insulin receptor, what you can have is a decrease in the purple and the blue. You can see you have silenced you've got the insulin receptor knockout mouse in 2 different kinds of mice, and you can see that the tumor weight is much lower, giving people a sense that perhaps insulin actually is a mediator of cancer growth in diabetes and in obesity when the insulin levels are high. But the key thing to remember is that what you can do in a test tube is very different than what you can actually do in a person, because the concentrations of various medications or entities may not be actually at the same place as in the tumor cell. So I'm just going to move on a little bit to the treatment of diabetes and obesity and how that might inform how we take care of patients and the role of the development of cancer. So I'll focus on the most common medicine that we use, and it's the first-line drug, metformin. This was a study done in the Netherlands that looked at the cumulative cancer mortality in patients who were on metformin and who were not on metformin. And you can see that if you didn't have metformin, if you had metformin use, you had a better survival than if you didn't have metformin. The same thing was not true for total mortality. So it almost looked as though things were lining up and doing well. They looked at cardiovascular mortality, where you also see a difference if you were on metformin versus no metformin. But if you didn't have either, but there was no effect on patients with no cardiovascular disease or no cancers. Again, another study that put together a meta-analysis looking at many studies where they looked at metformin and improved breast cancer survival, and the association is clearly in the right direction. It favors the use of metformin. On the other hand, just last year, and not yet published, is data from the Pamela Goodwin from a breast cancer meeting, which reported that metformin, if you actually randomize individuals to metformin or no metformin in early breast cancer, it had no effect whatsoever on overall breast cancer survival. And this was a multi-center randomized trial of over 3,600 patients. And the hazard ratio for the primary outcome, which was survival, was the same as for the placebo. And it didn't improve invasive disease, survival, or overall survival, regardless of estrogen or progesterone receptor status. And most of these people received chemotherapy and Herceptin at the same time. So despite a lot of data going back many years, association studies in populations showing an insulin lowering by 15 to 20% and slowed growth in rodents, metformin, when finally placed into a human being and done a randomized trial and done properly, did not show any benefit whatsoever. And what's interesting is that all these things happened around the early 2000s. And what that engendered was a large number as of 2012, and I didn't look up the data all over again, but there were 37 metformin studies in cancer registered at NIH.gov, all looking for, can metformin lower the insulin and as a result improve clinical outcomes? So this is the one I have actually found. There may be others, but the answer is no. Now, what about insulin? We use a lot of insulin in our in treating diabetes. And last year was the 100th year of the discovery of insulin and its use in humans. And in 2009, there was another flurry of action and activity and many papers, and I'm not going to go into them, showing reporting in very good journals that there was an increase in cancers in patients who took analog insulins, for example, glargine, many of these things, and including sulfonylureas or insulins, sulfonylureas being one of the very oldest of our diabetes medications. And the question is, what was really true about this? So these are all association studies and studies done for one thing and we're finding out something else. But in 2012, long after the original paper was published in the New England Journal, a study called the Origin trial was presented, and it treated patients with early diabetes and pre-diabetes with glargine insulin to see if that made a difference for cardiovascular disease. But at the end of the day, they were also able to see whether it made any difference in terms of cancer. And there was absolutely no difference in terms of overall cancers between the insulin-treated patients, and they were treated for many years, for about 7 years, and standard of care. So again, a lot of data about insulin in a basic science setting, but when we actually use it in patients at the doses we use, we don't see that. They also drilled down to look at this, and the same results were found, whether you're looking at all cancers or breast cancer or colorectal cancer. So I think that perhaps we can put to rest the fact that in a large population, this may not be a problem. It is possible that individuals who have specific predispositions may in fact have a risk but it's impossible to know how to identify that in terms of personalized genomic medicine. I think would be the only way to do that. So overall, we should, there have been conflicting results when the prospective trial shows no increase in evidence of cancer. And my important message is that in vitro studies really should be interpreted cautiously, because although they're very elegant in being able to define all aspects of the study, the intact human being much more complicated to study, you get different results at the end of the day. Here's a meta-analysis putting all of this together for all of our different treatments, looking at the obesity-only, type 2 diabetes, type 1 diabetes, the various cancer sites, and the treatments that we use for each of these. So pancreas is definitely affected by pancreatic cancer by insulin treatment, it seems. And often we find that patients will present with diabetes and 2 months later they present with pancreatic cancer. Metformin may be beneficial. And these, of course, are all association studies. These are not in any way randomized clinical trials. And you can see that insulin for some of the cancers are adverse, but not related to endometrium, although obesity is related to endometrial cancer, as is breast cancer, and and so on. So it's a complicated thing. I found other papers that contradicted this, so the jury is not out yet. In terms of lung cancer, there doesn't seem to be any clear-cut association with lung cancer or with thiazolidinediones. If we look at the most recent drugs that we have, for example, the GLP-1 receptor agonists, it is reported in rodents that you can get C-cell thyroid neoplasias in rats. There's been an enormous, in the beginning, we would have to test people for did they have evidence of C-cell neoplasias. And we did a lot of this kind of testing, but nothing came up. And we have moved on to thinking that these are relatively safe in humans. But we don't 100% know, but there's a lot of work, a lot of people have been exposed to these drugs. And the most recent drugs that in this class of medication are associated with tremendous decrease in body weight. So you can get 15 to 30 kilograms weight loss and have some very good outcomes. So these drugs are now being marketed for weight reduction. Whether they will be successful or not is unclear, because all of this is absolutely very new in terms of moving them from just the treatment of diabetes to the treatment of obesity in general. But this seems to be where things are going. DPP-4 inhibitors are another class of drug that are associated with pancreatic, have been associated with pancreatic ductal proliferation in rats. On the other hand, if you treated mice for a whole year, we have not had, they did not report pancreatic neoplasias in mice. Again, the human relevance is unclear, although we have all had a few patients who were treated with these meds and had significant abdominal pain, and some have actually developed pancreatitis. So it's not that it doesn't exist, but finding the ones with pancreatic cancer is, again, much more difficult. Another drug, which are the very useful SGLT2 inhibitors, which work as a diuretic and a sodium glucose exchanger in the proximal tubule, and are very useful for heart failure and diabetes. But initially, there was, in the initial trials, they showed that there was an increased tendency for bladder cancer in the active drug group, dapagliflozin, compared to all the controls. None of the other drugs in this category have shown this, but anyway, we should be cautious. And there have been times where we actually check red blood cells in the urine periodically just to make sure we haven't missed something. And this is another drug that is moving from just the treatment of type 2 diabetes to the treatment of heart failure in the non-diabetic population. So the exposure is potentially going to be much larger, and we really should have some way of identifying who might be at risk and how do we actually do cancer surveillance. So I would just like to conclude by pointing out the obvious, that cancer is a major complication in obesity and diabetes. and cancer surveillance should be part of our clinical care, which we don't have a very formal way of doing cancer surveillance at this point. And we need to determine which cancers we should focus on. And finally, how should we select diabetes medicines in the context of obesity and the increased cancer risk? I think I have one final slide, and that is the key. For me, the key issue is what kind of a strategy can we have that's community-based for weight loss and for physical activity? And maybe we need to dispense beans at every clinic visit along with their pharmaceutical drugs. So with that, I'd like to end, and thank you all for listening.
Thank you, Dr. Banerjee, for a very comprehensive presentation on cancer, diabetes, and obesity. This is very informative. Thank you very much. So our last speaker is Dr. Jian Zhang, who is an instructor in medicine at the Harvard Medical School and also an assistant attending in the computational oncology service at Memorial. Dr. Zhang earned a PhD in human genetics from McGill and also a postdoctoral fellow at Dana-Farber Cancer Institute. The title of her presentation is Integrating Genetic Ancestry to Understand Germline Contribution to Somatic Alterations. Welcome, and it's my pleasure to present you. You're muted, Dr. Zhang.
Sorry, I realized I'm on mute. Can you see my slides? And can you hear me? Okay, perfect. Yes. Thank you for inviting me. I'm going to talk about my work trying to understand how genetic ancestry contributes to germline risk in cancer carrying different somatic phenotypes. So we know both germline variants and environmental exposures can predispose to cancer development. Although germline and somatic genomes have been studied pretty extensively independently, but how they act jointly to promote tumor progression and influence treatment to treatment response and outcome has not been well understood. And we know that people with different ancestry inherit different risks and encounter different environmental exposures, and therefore they may carry different somatic profiles. And these molecular differences may provide insights into cancer etiology and epidemiology, and more importantly, understanding the biology of tumor progression. And the lack of knowledge about somatic differences between populations is a major barrier to implementing precision medicine for the underserved populations, because there's just very limited number of cancer cases from non-European populations have been sequenced in the research setting, and in general, matched normal samples are not collected and sequenced in routine clinical care. And I started studying genetic ancestry with this fascinating question introduced by my postdoc mentor, Dr. Matthew Marison at Dana-Farber. We know lung cancer is typically driven by genomic alterations of genes in the receptor tyrosine kinase RAS-RAF pathway, often allowing effective therapeutics targeting the pathway. It is well known that the frequency of EGFR mutations is about 45% in East Asian patients, which is much higher compared to European and African descents, which is around only 10%. And interestingly, in the Latin American countries, the frequency of somatic EGFR mutations ranges from 14% in Argentina to 25 to 34% in Colombia, Brazil, and Mexico, and around 51% in Peru. And more recent genomic studies from East Asia and African populations have suggested different distributions of tumor mutation burden and copy number alterations compared to the European populations. So despite the differences in patterns of somatic mutation between patients of different ethnicity, the landscape of ancestry effects on the lung cancer genomes for the Latin American populations has not been comprehensively described, and it remains unknown whether differences are due to ancestry-specific germline variation or rather to population-specific environmental exposures. And this is particularly important because the Native American ancestry is actually present to varying degrees in the modern Latin American populations, along with European and African ancestry. As you can see from this principal component analysis of 1,000 genome samples here, the Mexican and the Colombian populations are stretched along PC1 and the PC2, indicating the nature of the mixture in these populations. And it's worth mentioning that the Native American ancestry includes a significant component of East Asian ancestry that were derived through waves of migration across the Bering Land Bridge about 15,000 years ago. And therefore, the Latin American population can inherit a similar risk alleles from East Asian ancestry that is valuable in this kind of ancestry association studies. So in collaboration with the Latin American Consortium for the Investigation of Lung Cancer, we collected FFPE tumor DNA from over 1,000 lung cancer cases from these two countries as part of their routine clinical care. This includes 500 self-reported non-smokers from these two major research institutions in Mexico and Colombia, respectively. And this cohort is by far the largest lung cancer cohort, focusing on a population with the mixed ancestry. And we know next generation sequencing of known cancer genes has emerged as a common diagnostic tool to identify actionable mutations and to guide targeted treatments. And in this project, we used a clinical sequencing panel to identify driver mutations in these Latin American samples. At the same time, we wondered if we could use these clinical genomic sequencing data to analyze genetic ancestry. And so for this purpose, we developed a computational pipeline to infer ancestry based on the off-target rates in this sequencing panel. So in targeted cancer gene sequencing, the entire genome is usually covered by off-target rates at very low depths, around 0.5x. And if you look at this, the distribution of these off-target rates, you can most of the regions are actually uniformly covered by these off-target rates at very low depths. Although the cancer genes are mostly targeted at higher depths to discover somatic mutations, we can actually infer germline information from these off-target rates. And in our approach, briefly, we use off-target rates to code germline SNPs genotypes, and then we code ancestry based on these germline SNPs. And we also benchmarked the accuracy of our ancestry identification approach. Here we selected a subset of cases for SNP array and low-pass whole genome sequencing validation, and we saw high correlation in this analysis. Especially we observed high correlation of tumor and normal ancestry inference, suggesting that we can accurately infer genetic ancestry from tumor-only DNA sequencing. And we can actually use this. And actually what's cool about this method is that it's not platform dependent, meaning that we can actually infer ancestry from any types of clinical genomic sequencing platforms. So, so using this approach, we first correlated the mutations in EGFR and the KRAS in these patients, and in these patients with the Native American ancestry. And we found that EGFR mutation frequency is increased with the proportion of Native American ancestry, whereas KRAS was reversely correlated. And when the Native American ancestry is close to 100% in these patients, the EGFR mutation frequency is similar to what we observed in the East Asian patients, which is around 50%. To better understand the relationship of ancestry and exposure-induced mutagenesis, we tested the ancestry associations in the RAS pathway oncogenes, adjusting for mutation signature. And we found that we saw a positive correlation of Native American ancestry with EGFR and negative association with KRAS after adjusting for smoking signature. And we also observed the same trend in the never smokers. KRAS was significantly associated with smoking signature, but it was also significantly associated with ancestry in the non-smokers, although the association with KRAS in reported never smokers trended toward significant, but it was actually not significant in this study, perhaps due to limited sample size. So we then asked if smoking-related signature modified the effect of ancestry on KRAS. So in this model, we added the interaction of ancestry and the smoking, and the interaction term is not significant, meaning that ancestry is not the ancestral effect is not different or dependent on the smoking-related mutational signature or mutational process for KRAS. So together we conclude that the Native American ancestry was associated with EGFR and the KRAS in Latin American lung cancer patients that are independent to smoking-related activities. So in the previous analysis, we only correlated somatic mutations with ancestry, with global ancestry, the overall ancestry. However, this overall ancestry or global ancestry can also correlate with other non-genetic factors, for example, discriminations and access to healthcare. On the other hand, we can also assign ancestry to each locus across the genome, so-called local ancestry inference. And we are particularly interested in the local ancestry because we want to dissect germline factors from environmental factors related to ancestry. And associations between local ancestry and the phenotype may provide a more direct evidence of a genetically driven phenotype. Because unlike global ancestry, this kind of locus-specific ancestry is not expected to be causally associated with environmental or non-genomic factors, non-genetic factors. For example, in this plot, you can see that we can assign different ancestry to different genomic region in this individual with mixed ancestry. And we also benchmarked the accuracy of our local ancestry inference from panel sequencing. This is a benchmark against germline SNP array data, showing that we can actually infer local ancestry accurately from tumor sequencing of tumor DNA sequencing of a panel of cancer genes. So using local ancestry, we constructed a local ancestry risk score to quantify the phenotypic heritability. So I won't go through all these details here, but essentially this local ancestry risk score is defined as the sum of the Native American ancestry across each associated region weighted by a cross-validated Z-score for that region. Long story short, this approach is conceptually similar to the polygenic risk score, but in our case, we use local ancestry instead of SNP genotype to assess the germline risk here. And we then performed another logistic regression, including both the local ancestry risk score and global ancestry as covariates. And we found that the local ancestry risk score was significantly associated with EGFR and KRAS mutations, whereas a local global ancestry was no longer significant in this joint model. So our findings suggest that genetic loci probably specific to the Native American ancestry may modulate the risk of lung cancer harboring EGFR or KRAS mutations in the Latin American populations. Just to sum up this part, the genomic landscape of lung adenocarcinoma is strikingly varied in Latin American patients with mixed ancestries. And we demonstrated that the Native American ancestry was correlated with EGFR and the KRAS that can be effectively targeted by small molecule inhibitors. And these associations are independent to smoking-related activities, suggesting a germline risk of the developing EGFR mutant or KRAS mutant cancers. I also want to emphasize that disparities in access to genetic testing have been observed among Hispanic lung cancer patients in the United States. For example, Hispanic patients were less likely to be tested for the EGFR mutations than other populations. And I hope that our findings can improve the genomic diagnostic testing for patients from the underserved populations. Well, it's always important to sequence more samples, more patients with non-European ancestry. We wondered if we could perform ancestry analysis in existing clinical genomic data sets. For example, one of our ongoing collaboration with Foundation Medicine is to make ancestry codes for all samples already sequenced at the Foundation Medicine. And this is really helpful because reported race and ethnicity is not available in this cohort. And this cohort is actually pretty large. So far, they already have 300,000 samples sequenced. And what's surprising is that although the majority of these patients are European, we identified over 30,000 samples with African ancestry, and this makes this cohort is perhaps the largest African cohort in cancer so far. And using this data, we replicated this known depletion of VHL mutations in renal cell carcinoma in patients with African ancestry compared to European patients. And now we are working on to identify more ancestry-associated cancer driver genes based on the Foundation Medicine cohort. We're also interested in understanding how ancestry-associated genes affect outcome. And this is just an example of from the MSK impact cohort. And you can see that even these patients received genomic testing and treatment at the same hospital. There are differences in terms of survival in these patients, and patients with African ancestry tend to have worse overall survival compared to their European counterparts. And the differences is even larger when you look at the renal cell carcinoma, where African Americans tend to have lower VHL and PBRM1 mutation frequency. As discussed earlier, we can ignore social and economic and environmental factors that probably explains most of these differences in the outcome. But we also need to understand whether there are biological differences, and perhaps local ancestry can give us some ideas whether there's any genetic factors underlying this. So I would like to thank my colleagues at Dana-Farber, Foundation Medicine, and MSKCC for working on these very difficult questions together, and our wonderful clinical collaborators from Mexico and Colombia. And I just started my own lab at MSKCC, focusing on understanding germline influences on outcome in multi-ethnic cohorts. And please let me know if you are interested in collaborating, and thank you for your attention.
Sorry, thank you very much for this interesting presentation. We really appreciate. Because the meeting, actually, the panel went a little bit more than we expected. We will have one question and probably will conclude. So there is a question for Dr. Daniels McDougall. Is there a specific reason with respect to nutritional content that navy beans were used? Although Hispanic Latino participants did not make up a large demographic within the study, other types of dry beans, example, pinto, black, red, are more common within diets.
Sure, I'll try to answer quickly so there's room for more. So the answer is all dry beans have these prebiotic properties. So I don't think that we need to push one particular type in terms of public health promotion. But the reason why I focused on it for this first trial in this particular fashion was because a lot of the preclinical data actually focused on navy beans, because they are distinctively rich in some of these bioactive compounds, or at least the bioactive compounds are what kind of differ between the different types of beans. So like phosphatidylserine is really high in white beans. Apigenin is really common in navy beans, higher amounts compared to other beans. But also they're really rarely consumed in the US. So it's something that's nice to think about when you're doing an intervention. You don't want something that people are always eating all the time. And they have a really, really mild flavor, and they can be incorporated in all sorts of things. So we actually even had a cookie dough dip recipe that we didn't make up. There's like 55 versions on the web that the base is navy beans. So it's kind of just a few things, but I don't think in terms of public health promotion, we should try to get everyone to eat one type of bean. We should just try to get people to eat more beans, however they're going to eat them.
Yeah, good, thank you. Yeah, so the last question is, there are a lot of studies that were done, migrant studies, as you know, in epidemiology, where people came from Japan to Hawaii, and in Hawaii, they stayed long and they tried to assess risks associated with different cancers, especially for colon cancer, with meat and other things. The evidence is really very small. But I was just wondering, did anybody has looked at, as people move from these areas, their microbiomes, whether the microbiomes are the main reasons for the differences in cancer risk as people come from poor developing nations to more developed nations.
Is that question for me?
Yeah.
Okay.
It is.
Well, so Stephen O'Keefe has done quite a few studies in this area in terms of epidemiology. And then there actually was a feeding trial where they had Africans living in Africa who have a primarily maize staple diet. And then they had African Americans, I believe it was in Philly, who were eating an American style diet, and they swapped them in a controlled feeding study. And of course, the fiber content between those two diets is massively different. And they did see reciprocal changes in the microbiome and the colon cells. That was a really beautiful, early, small study that had these dramatic effects that everybody else is trying to reproduce on a larger scale. Turns out that's actually hard to do. But I do think that, carbohydrates more than ever are getting a really bad rap. But people don't separate the fact that fiber is carbohydrates. And so we're also pushing high fiber diets. And I think it's really important in terms of those messages that people don't think they have to stop eating all their carbohydrate staples. They just need to focus on the ones that actually provide the higher quality carbohydrates instead of that. And I mean, that is in the nutritional recommendations, But I think at a cultural level, we're not quite hitting the mark on that.
Thank you. I think, there isn't more questions, so I will conclude this part of the panel and I will give the audience to Dr. Salifu.
Thank you, Dr. Demisi, and all the speakers in this panel for wonderful session again. And I'm sure the audience is appreciated and then have new knowledge to take home with. As we come to a close, I would like to summarize a few key points for you. In session 1, we focus more on colorectal cancer. In session 2, we focus more on pancreatic cancer. We had a keynote speech by Dr. Mitchell on the issue of cancer health disparities and how to improve it. And then in this last session, we talked about cancer and comorbidities and some of the modifiable risk factors that we can know, and in the hope that we can improve care for these patients. So with that, the first order of business is really to thank a lot of people, but the first person for us to thank is Dr. Laura Martello-Rooney. Dr. Laura Martello-Rooney has been incredible. She's been the pillar of this conference for the past 7 years. It's just amazing how, she's been able to make this happen every year. And it's always very nice to have such a distinguished panel of speakers and panelists and moderators come together and bring new knowledge to the table. So thank you, Laura. And we hope that next year to be more fun. We would be able to come in person and be able to meet the old faces again and then have the interactions and connections. The second person I'd like to thank is Dr. David Stevenson. He is really my partner in this conference. We have been co-directing this for 7 years now, and unwavering, he comes to every one of these conferences, knowing his busy schedule. And so thank you, Dr. Stevenson, for that. The third person I'd like to thank, the external advisory committee members. That is Drs. Antonio Baines and then John Carruthers. You've already, heard them moderate 2 of the sessions. They have been the external partners that have been advising our group for the last 7 years and making sure that, we are in line with what we're supposed to do. So thank you to all of you. For the audience, the speakers, I'd like to thank all of you. Cancer is a big deal. The hope is that, in the future, we would live with cancer, not die from cancer. All this stuff is towards that goal where we will convert this bad disease into just living with it and making sure that underrepresented minorities have the same opportunity like anybody else. So that is what this is all about. So I like the idea of the precision medicine and all the things that we can do to equalize therapy between the various ethnic backgrounds. So with that said, I know you haven't traveled, but it's a weekend. I wish all of you a sound weekend. And then if we have picked up collaborations here and there, let's follow through. Make sure that those collaborations yield fruits, and that when we come together next year, would have expanded our domains and are looking forward to discussing new things. So with that, I would say thank you to all of you, and then goodbye.